And go, sir. We are live.
Yes. Myself, Dr. Vishal Dave. I am medical advisor at Intas Pharmaceuticals Limited. On behalf of Intas Pharmaceuticals, I welcome you all for this Perfection series under Central ISAR. I am honored to introduce Dr. Monica Singh, the co-convener of this session. Dr. Monica Singh is professor at Ellen Medical College, Bhopal. She is consultant reproductive medicine, Bhopal Fertility and Endoscopy Center. She is honorary secretary MP chapter ISAR, and she is also vice president of Bhopal Obstetrics and Gynec Society and Bhopal Menopause Society. Madam, now I am handing the session to you. Over to you, ma'am.
Thank you so much, Dr. Vishal. And at the outset, I would like to thank ISAR for giving us this platform to conduct the very focused academic series of Perfection series, in which our endeavor is to talk completely and exclusively about one subject. The first Perfection series episode was on ART law, which was very well received. The second was on genetics, which was totally high tech and very enthusiastic. And the third is on genital tuberculosis, because how important that is, we all know. India contributes a little bit about the sessions today. India is contributing to 28% of TB cases globally. And although lungs are the primary site affected in TB, extrapulmonary tuberculosis, of which genital tuberculosis is a part, constitutes about 16 to 20% of all TB cases. So it's very important to know about EPTB. The entire data or estimates we have about EPTB or extrapulmonary tuberculosis is just the tip of the iceberg, because a considerable proportion of these cases are difficult to diagnose, and even if they are diagnosed, they are not notified. That is the tragedy behind extrapulmonary tuberculosis, and sometimes the sites are so inaccessible that the patient and the health provider doesn't know that the disease is growing and spreading. That is why National Tuberculosis Elimination Program, or NTEP, was envisaged by the Government of India in January 2020. And this is also a sequel to RNTCP, that is the revised National Tuberculosis Control Program. And this has the target of achieving a TB-free India by the year 2025, by providing universal access to TB control services all over the country. NTP has implemented the National Strategic Plan, or NSP, and this is based on 4 pillars. The first pillar is preventing the disease. The second pillar is detecting the disease. The third pillar is treating the disease. And the fourth pillar is building. Building means building and strengthening policies in the government in the form of high-tech institutions and human resources. In the public health interest, the Government of India on 16th of March 2018 has made tuberculosis a notifiable disease, making notification of each tuberculosis case mandatory. This notification has to be done by healthcare providers and the clinical establishments. Number 2, laboratories. Number 3, even by the chemists, druggists, and pharmacists. And number 4, by the patients themselves. They will notify, self-notify, and the treating medical practitioners will also notify. If not notified and appropriate public health action not taken, this is a punishable act under the provisions of sections IPC 269 and 270. Such is the importance of the disease. And it is endless talking about genital tuberculosis. We have so many experts in India who have absolutely revolutionized the disease treatment and management in the country, which is going to lead to a safer India, a healthier India, and a better world. So over to now the beginning of our series. And for this, I will first introduce my president of ISAR, Dr. Nandita Parshedkar. Madam is going to give her presidential address after the first talk, because she is right now presiding in another meeting. But it is my pleasure to introduce the president of ISAR 2022, president of FOXI 2019, president of IAG 1718, head of the steering committee Manyata Project 2019, AMOX president 2022, MOX president 1617, and an international representative to FIGO. Madam has got so many awards, so many publications. She's a great teacher, and I'm honored to be associated with ISAR in carrying forward the Perfection series. Next, I would like to thank our Honorary Secretary General of ISAR, Dr. Sujata Kar. Dr. Sujata Kar is at present abroad. She'll not be able to join, but she's always supported all our academic ventures wholeheartedly. She's a very senior ART specialist of Bhubaneswar and is the recipient of several awards. Her publications and research interest is well known all over the country. My introductions will not be complete if I don't talk about Dr. Sunita Tendulwar, who is absolutely the spearhead force, the action force behind the Perfection series, because there was a time when I was struggling to get this forward. I didn't have the platform. I had ideas, but I didn't have the vision to implement it. And it was Sunita Tendulwar, Madam, President POGS 2122, Chairperson and Founder Honorary Secretary ISAR MSR, Senior Vice President ISAR, at present President IAG 1920, and she has got the extraordinary achievement of being the gynecologist behind India's first stem cell baby and the world's first at the age of 45 in 2018. Madam has been the recipient of several awards, including a letter of appreciation from the President of India in 2012. I'm so proud of Madam, and I wish her all the best for the forthcoming elections. Next in my series of introductions is my co-convener, Dr. Randhir Singh, who is a senior ESHRE certified nephrologist, and he is the immediate past chairperson of MP chapter of ISAR, scientific director of Bhopal Fertility Endoscopy Center, associate professor in Ellen Medical College, Bhopal, Organizing Secretary ISAR 16, Organizing Secretary ISAR Embryology 18 in Bhopal, and the Organizing Chairperson of the very successful 27th Annual ISAR 2023 Bhopal. I welcome Dr. Randhir Singh to take our program forward by introducing our chief guest and the guests of honor. Thank you.
Thank you, Dr. Monica. First of all, I am very proud, privileged to be given the platform by the ISAR President, Dr. Nandita ma'am, Secretary Dr. Sujata Kar ma'am, and Vice President Sunita Tendulkar ma'am. So to begin with, without wasting time, we have got today the chief guest and the guest of honor. The chief guest is respected Dr. Manish Bankal sir, and the guest of honors are IFS President Dr. K.D. Nayyar sir and Professor Dr. Abha Singh ma'am. So now introducing Dr. Manish Bankal sir. He's a legend. Dr. Manish Bankal sir is a legend of, you can see, infertility practice, who was the draft member ART bill when he started in ICMR 2010. From there, he and NARI, everybody knows that NARI was the official publication of all the data which all private IVF centers, more than 1,000 initially 10 years were there. So to begin with, he's at present medical director, Nova IVF Fertility, one of the largest IVF groups in India, chains, awarded the BC Roy Award by the Medical Council of the India in 2017, past president, ISAR, 2012 to 14, regional representative, International Committee of Monitoring ART, senior associate editor, Journal of Human Reproduction Sciences, the official journal of the ISAR, member board of directors, Poseidon Group. It's a very achievement for India. Member Surveillance Editorial Board, IFFS 2011, 14, 17, and 20. Member Board of Directors, Pacific Rim Society of Reproductive Medicine, PSRM. Founder Board Member, Aspire, and member of Draft Committee, as told you. So I'll request Dr. Manish Bankal sir to say a few words for this webinar.
Thank you very much. And really thank ISAR and the office bearers and the organizers for giving me this opportunity. The idea behind the Perfection series is really unique because you are picking up topics which are very relevant, important, and many times very confusing. And the word perfection, I assume, means helping people to be perfect in these difficult topics. And today's topic of genital tuberculosis is one such really complex topic, because right from how do you diagnose, how do you treat, there are a lot of controversies, especially when we see a lot of women with unexplained infertility or recurrent IVF failures who are believed to be suffering from silent genital tuberculosis. And this is a big dilemma that every clinician faces in how do we go about diagnosing, and should we give empirical or definitive anti-tuberculosis therapy to these women. So in that sense, this is a very, very relevant topic for every clinician. And I hope at the end of these 2 hours, we will have some pointers as to how do we move in this particular direction. With this, I wish you all the very best, and I really look forward to more such series. Thank you very much.
Thank you, sir.
Thanks a lot, sir, Manish sir. You're always a spiritual support from the scientific, because I have seen in Bhopal also, not only you, your whole Nova team, your son, everybody was available in each and every at 8 a.m. in the roundtable conferences. Thank you, sir. Our guest of honors, we have got 2 guests of honors, Dr. K.D. Nayyar sir and Dr. Abha Singh ma'am. So I'll just to introduce the K.D. Nayyar sir. I'm very privileged to have my K.D. Nayyar sir, because to introduce to him, I'll say in last 10 years, I have seen the K.D. Nayyar sir's paper always either in ASRM or ASHRAE, both. So at present, he's the IFS president, and he has got many special interests, especially poor responders. 25 international presentation, I told you, SRM, Aspire and ASHRAE. 22 international presentation in ASHRAE, and he has a star award for presenting continuation of the papers in SRM 20, 21, 22. And I request K.D. Nayyar sir to say a few words of genital tuberculosis, because I think it is one of the greatest cause, and now the infertility, as informed by the WHO, is now infertility is now under the chapters of the diseases which are notified by the WHO, and it's up to 10 to 20% of Indian couples are infertile. So I request to say a few words for this webinar, K.D. sir.
Hello, yeah. It is a privilege for me to be associated with this webinar. I'm thankful to ISAR for inviting me here. As the webinar is about female genital tuberculosis, a complex problem in Indian scenario, although we have been dealing with tuberculosis from ages, but female genital tuberculosis is causing the infertility segment which we are treating. And like it was mentioned in the introduction, almost 16 to 20% of the women are having this female genital tuberculosis, and 40 to 50% of the tuberculosis patients are suffering from infertility. And we got to have very straightforward, clear investigative modalities and how to diagnose it and how to go about and treating it. It has to be very clear. Like Dr. Monica mentioned that the idea is to finish tuberculosis by the year 2025. I think we all must work toward this, diagnosing it in a early stages so that the damage is not done to the pelvic organs, and treating it. That is the aim, to diagnose it early and to treat it completely. That should be the aim. Thank you very much.
Thank you, sir. Thank you so much for joining.
Thank you, sir. Thank you, sir. And I wish that you will be the part of the webinar in coming for 3 hours. And the other guest of honor today, I'm very privileged, is again that Dr. Abha Singh, professor. I'll call him as a professor because when I was in final year in Bhopal in 89, she was my professor there, and she taught me the ABCD of Gynae. Though I did not take the Gynae as my PG, but she's always in my all scientific books. She only guided me how to read the Jeffcott and other books. So to introduce, it's at that she's I think all the Chhattisgarh chapter doctors and the viewers must be knowing that Abha Singh madam is in Chhattisgarh. She's like the patron, the force behind for every organization. As I'll read the CV, we can see she's a vice president, SOVCI, founder, and the present president of AICG, patron ROGS, IFSNG, IMS Raipur, past president ROGS, IMS Raipur. So you can see in every society, whether it is IMS or IMA or Foxy, Abha Singh ma'am is the force behind. And Dr. Manoj Chelani, you know very well, when we founded the IFS chapter there so madam was the behind for the ISAR also. And she has been awarded the CM trophy for meritorious service in 2002. Padma Shri S.K. Mukherjee Award 2005, Rashtriya Gaurav Award 2009, Best Paper in Oncology 2013, Health Icon of the Chhattisgarh by the Times of India in 2016, ex-Dean, the Government Medical College, Raipur, ex-Vice Chancellor, Dean Dayal University Medical Sciences, presented more than 100 papers and posted in state and international papers. She has written almost 80 articles in the different index journals and the books, conducted live workshops of NDVH, colposcopy, programmed labor, uterine ligation, and the fields of interest in infertility, medical disorders of pregnancy, minimal invasive, and vaginal surgery. This is just a tip of iceberg. She has got many things, and I know every gynecologist or any doctor related to gynae, उसके ऊपर मैडम का कहीं ना कहीं directly or indirectly साया जरूर रहता है. So I request Abha Singh ma'am to say a few words, and I am very privileged that you are a part of this scientific webinar. Welcome, ma'am.
Thank you, Randhir. It's very nostalgic for me, the journey you have taken me to, and thank you very much for your kind introduction. First of all, I would like to thank ISAR, Dr. Nandita, Dr. Sujata, Dr. Sunita, Monica, Randhir, and others who are responsible for today's brilliant topic, tuberculosis. Now, we know that our country is like the hotspot of TB, and we have the highest burden of this disease. About 2.7 million people are affected every year. Also, 26% of these develop the multiple drug-resistant tuberculosis. And the number of deaths is also considerable, 4 lakhs per year. So it was very natural to host the One World TB Summit in Varanasi recently. And Modi ji, our Prime Minister, has reiterated India's commitment to eliminate this TB from India by 2025. Now, whether we can all do it by 25 or not, our goal should be to accelerate the momentum to eliminate this disease, which is very important from the perspective of the doctors who are treating, because sometimes it's difficult to diagnose, sometimes the investigative approaches are not, people are not aware of those approaches, and sometimes the patient cannot afford it. And from the patient's perspective now, after MDR, we have XDR. So much drug resistance is there. And whatever drugs are now being used, they are very, they are causing a lot of adverse reactions, and the life of the patients are really at risk. And you do not know the length of the treatment. It may continue for very long. And usually it leads to sometimes even mental illness amongst these patients because of the long run of the disease. So indeed, I should say, a very good platform to discuss tuberculosis. Thank you very much for having me here.
Thank you so much, madam, for joining and blessing us.
Thank you, ma'am. Thank you very much, ma'am. Because, and I think we'll all expect that, madam, you be part of this 3 hours, and because inputs, nothing like the inputs, what the quantum we get in the government setup, which you have got the experience of patients from the Madhya Pradesh when you were in the MP, and then after we have got Chhattisgarh, because these two are the earlier also they were the Bimaru states, and still we are not on the top states. So I think your experiences will be matter to us, ma'am. And now without wasting your time, now I'll ask Dr. Monica to continue the webinar. Next.
So in this series, to carry the program forward, I invite my program coordinators. My program coordinator is my dear friend and colleague, Dr. Shabana Sultan, who is professor in the Department of OBGYN GMC Bhopal. She is an avid academician, has presented several papers in national and international journals. She is a member of the esteemed PPH team in Sevagram. She has been the past Joint Secretary, Treasurer, and is at present the Dynamic Secretary of the Bhopal OBGYN Society. She is also an active executive member of NPSR. She is doing interesting projects along with the Harvard University and has got special interest in gynae oncology, high-risk pregnancy, and is a keen master trainer of the cervical screening program. Welcome, Dr. Shabana. And my second program coordinator for today is Dr. Purnima Tiwari. And she has been a very great academic force behind this webinar, who has done a lot of research, a lot of putting together data for me, helping me out with the cases and everything, calling up faculties. I thank you, Purnima. She's a very, very bright gynecologist who has done her MBBS from LHMC Delhi, MS OBGY from MAMC Delhi, and has been a member of the National Academy of Medical Sciences. She has trained in gynec oncology. She's been awarded Foxy Traveling Fellowship. She has also received the ICOG Fellowship in Reproductive Medicine from Omega Hospital, Nagpur. She has got an advanced diploma in ART in Reproductive Medicine, associate member of our Royal College of Obstetricians and Gynecologists, and has presented several publications. She has many papers and publications to her credit. Welcome, Dr. Purnima.
Thank you, ma'am. Thank you, ma'am.
Now, Purnima, you can start the first session, please.
Yes. For the first session, I invite the chairpersons. I welcome Dr. I welcome Dr. Seema Pandey, ma'am. Ma'am is Director, Seema Hospital Private Limited and Eva Fertility Clinic and IVF Center in Azamgarh, UP. Ma'am is very dynamic President of Azamgarh Obs and Gynae Society and also National Executive Committee member of ISAR and ISPAT, which was held recently in Varanasi, and we all know that it was a grand success. Ma'am is also co-author and co-editor of various chapters in the book, and she is also reviewer of National Journal. Ma'am is executive board member of Commonwealth Association for Health and Disability. She is having a special interest in PCOS and adolescent health, and also running her own NGO, Surbhi, for women health. So I welcome Dr. Seema Pandey, ma'am. Thank you for joining us, ma'am. And I invite the next chairperson, Dr. Jagrati Kiran Nagar, ma'am. Ma'am is present president of Sagar Obs and Gynae Society. Very dynamic president, ma'am is. She is associate professor in Obs and Gynae department of BMC Sagar. Ma'am is organizing committee of AMPOX and very senior member of AMPOX, and has several publications into her credit. And ma'am has been invited as faculty to MPOX Bhopal and Yuva Foxy Bhopal. I welcome you, ma'am, Dr. Jagrati, ma'am. Thank you for joining us. So I hand over the session to the chairperson for introduction of our next speaker, Dr. Manoj Chelani, sir.
Dr. Seema and Dr. Jagrati, any one of them is present? Okay, I don't think.
Thank you so much, ma'am, for giving me this opportunity.
Okay,
And-
Jagrati is there?
Yes, ma'am.
Okay, yes, yes. Welcome, Dr. Jagrati. Yes, you can.
Thank you
introduce-
so much.
Yeah.
This is my proud privilege to introduce Dr. Manoj Chelani, sir. He is Director of Ayush Hospital and Test Tube Baby Center, Raipur. He is Managing Committee member ISR, Chairperson-elect Chhattisgarh ISR 2023 to 2025, Scientific Chairperson National ISAR Embryology Conference 2022 Raipur, Chairperson Medical Disorder and Pregnancy Committee FOXY, past President Raipur Obs Gynae Society, Organizing Secretary North Zone Yuva Foxy 2011, Chairperson Urogynecology Committee, Indian Menopause Society, Founder Chairperson Chhattisgarh IAGE, Vice President Chhattisgarh ISOPAR, Vice President Chhattisgarh IMA, awarded by Chief Minister of Chhattisgarh. So, welcome, sir.
Thank you, Dr. Jagrati ma'am, for such a kind introduction. So at the outset, let me just share my, can I be allowed to share my screen? Yeah. So at the outset, I would like to thank Dr. Nandita Palshetkar ma'am, President ISAR, who is also the FOXY representative of FIGO, And thanks to Dr. Sujata Kar ma'am and Dr. Sunita Tandulkar ma'am, who is really working hard towards this. And I wish her all the best for her forthcoming forthcoming elections. I'm sure she'll be a winner and she's really working hard. And I'm really, really thankful to Dr. Monica Singh and Dr. Ranveer Singh, sir, the brain behind this vision for this series. That's a very, very good idea. And they're really working hard to make it a grand success and bring everyone together. And thanks to Dr. Manish Bankar, sir, Dr. K.D. Nair and Professor Abha Singh ma'am for being the guest today. And thanks to Dr. Purnima and Dr. Shabana. A special mention for Dr. Purnima, who has really worked hard, who has coordinated with me to get all the information and got this thing. So thank you very much. And yeah, so like one thing is like which really bothers me that in this century, we are still talking about anemia, we are talking about tuberculosis, and India has progressed so much, but still there are certain things we are struggling to conquer, and tuberculosis is one of them, though I mean government is really working hard and we have really come a long way. I mean, there was a time where there was a taboo regarding tuberculosis. People used to hide it. They didn't want people to know that they are suffering from tuberculosis. But as Dr. Monica ma'am already said, and we all know that now it's a notifiable disease. And now things are different. The drugs have changed and people come forward and get the full treatment. And as our central government has a vision that by 2025, we should be able to eliminate it. But tuberculosis is really creating a havoc. And especially like when we are working in the field of infertility, we see that, it really tempers our mind. And really, we have to struggle to get success in cases of patients suffering from genital tuberculosis. So without much ado, I would like to start my topic. Though most of the things will be covered by the subsequent speakers. So it will be a broad outline on tuberculosis and infertility. So just a broad overview. So we know that it's really a havoc, and almost 8 to 10 million cases are there globally, and it does affect the infertility patient also. When we see that around 5 to 10% of those infertility patients have genitally this thing, and 10% of women with pelvic tuberculosis have a concurrent urinary tuberculosis also. So although genital tuberculosis can occur in any age group, but a majority of them are seen in reproductive age groups between 20 to 25 to 40 years of age. And the female genital TB used to be the commonest cause of tubal infertility in women in TB endemic areas. And symptomatically, only 10 to 15 years of primary infection is there. And in most cases, we see that secondary to pulmonary TB. So that's the whole thing is there. And we are well aware that it's spread by hematogenous route, by lymphatic or direct route, or by its ascending routes. And when we talk about the organs affected, endometrium, we know that it gets affected, but it's not necessary. It is not a good indicator for the presence of genital tuberculosis. Even the normal endometrial tests are not rule out genital tuberculosis. And the frequency of lesion found in the genital tuberculosis, that majority of the cases, fallopian tube are affected. Then comes the endometrium and ovaries. So when the fallopian tubes gets affected, its normal anatomy is distorted. The tubes become rigid and fixed. There are addition with nearby structures and develops perisalpingitis. There's tuberculous salpingitis. There's loss of femoral structure. So really hampers the functioning of the fallopian tube. So it really creates a havoc to the fallopian tubes. Now endometrium does also gets affected due to a dual blood supply and proximity to the fallopian tubes. There's an ulceration. It may present as there's a caseous necrosis and hemorrhages also there. Ovaries also get affected. There's ovarian tuberculosis. On the surface tubercles, there's adhesion, there's a thickening of capsules or caseating abscess on the ovarian surface is there. Now we see there's a massive cervical tuberculosis there. In this case, there's ulcerative or bright nodal lesion is seen, and we have to differentiate between the cervical carcinoma. And the infertility occurs because of loss of normal tubal anatomy and endometrial tissue, and it's very difficult to treat medically and surgically also. At present, the patient may present to us with the vague things. It's like when we are not, if you are not aware about the, tuberculosis, we are not very conscious about it, we may miss it. So patient may present with menstrual disturbances, she may come with pelvic pain, she may present with infertility. So looking at the present scenario of the country, we should always suspect that suspicion should always be there in the mind, because if there's a suspicion, then we'll try to rule out it and then we'll move forward. So that is very, very important. And it may at times be asymptomatic, so there has to be high index of suspicion. In acute phase, the patient may present with pelvic pain, fever, and vaginal discharge. And there may be subtle sign that could indicate a problem, especially if a woman has suffered from pulmonary tuberculosis in the past or had a close contact with a TB patient. And she may present with menstrual abnormalities, pain, pelvic area, and infertility. So it's very important that we take a proper history of the patient, whether she had a tuberculosis in the past, any family member is having a tuberculosis. So that is very, very important. And patient, as I said earlier, there are still some patient who has a taboo regarding tuberculosis. So they try to hide it from their their physician. So it's very, very important that we elicit that history, and we should find out if she has taken the anti-tubercular drugs in the past. So these things can help us to diagnose it and treat it accordingly. So when we do the general examination, there may be at times there may be nothing remarkable about it. Patient may present with anemia or loss of weight, and if he advised chest X-ray, at times the X-ray may be normal or may show signs of active tuberculosis. So on examination, per abdomen may be normal, or rarely may find irregular tender marks in lower abdomen rising out from the pelvis. And we may get Doyle feel due to matted intestine, because once the tuberculosis affects the intestine, there's a certain kind of feel which is called as a Doyle feel. There may be evidence of free peritoneal fluid, which is rare, and tubercular ascites when incystis mimics an ovarian cyst. When we do PV, in most of the cases, it's a negative. There may be restricted mobility and adnexal mass may be there. There may be thickening of tubes which may be felt through lateral furnaces. So when we do PV examination, we may feel a thickening of tube, and nodules may also be felt through posterior fornix. And at times, bilateral pelvic mass of varying size, quite indistinguishable from that due to pyogenic infection, may be felt. So, and presence of textile tubo-ovarian mass in unmarried girls is generally TB if ovarian plasma are ruled out. So we have to be really aware, do proper examination and suspect it, and then we should go ahead with the investigation. And aim of this investigation is to identify the primary lesion if possible, and we have to confirm the genital lesion as well. So for that, blood test, leukocyte and ESR values may be raised, and periodic evaluation is of value to evaluate the progress. Montel text in today's scenario is a little bit questionable. Chest X-ray for evidence of active or healed lesion should be done. Ultrasound is not a diagnostic tool for tuberculosis, but it may aid us by telling us about the adnexal mass, by telling us about thickened omentum, ascites, and hydrosalpinx. And diagnostic uterine curettage can be done on a week preceding menstruation because tubercles surface premenstrually. So that is very important. And material should be sent to the lab in two portions. So one part you will send in formal saline to detect giant cell system. We should know that histologically TB can be detected only 10% of cases. And false positive test may be there due to presence of chronic lesion like TELC or catgut granuloma or sarcoidosis, and we may get false negative due to improper timing or less incidence of uterine infection. So, and the other part is sent by culture in LJ media, which is the gold standard, and there may be there's identification of AFB by Zeal-Nelson stain and nucleic acid amplification. So combination of fluorescence staining techniques along with one of the acid-fast staining techniques or histopathologies achieve sufficient sensitivity and specificity for the diagnosis of female genital tuberculosis. And nucleic acid amplification, the endometrial tissue or menstrual blood is collected on first day of discharge, and it can detect fewer than 10 organisms in clinical specimen and is important as genital TB is usually paucibacillary. And first day of menstrual discharge is collected in a pipette and subjected to nucleic acid amplification and culture. So that this is quite a good sensitive test. And positive report on air-free microscopy, PCR culture, and histologic gives the diagnosis, but a negative report does not rule out the tuberculosis. So we should be aware of these things. And we should also send tests for sputum and urine, lymph node biopsy, and biopsy from lesion in the cervix, vagina, or vulva if present. So HSD is contraindicated, and HSD should not be done to, for the diagnosis per se. Sometimes HSD is done when we are not aware that patient is already suffering from tuberculosis, and we may get certain findings which points towards the presence of tuberculosis. Here we see the normal picture of the HSD. And in cases of tuberculosis, we will find the rigid lead pipe tubes with nodulations at places, or tobacco pouch appearance with blocked funnel end. There may be presence of cobble stool appearance due to intraluminal scarring effect and the effective radiographic sign of intraluminal adhesions. And the beaded appearance of the tube with a variable filling density. This is quite a times often seen in these cases. And there's another picture like golf club tube. So we should be aware of the findings which can be seen in HSD. Other modalities which include our imaging by ultrasound, CT or MRI, but they are not diagnostic. And in subsequent talk, this will be discussed when the imaging in cases of tuberculosis is discussed by the speaker. Laparoscopy may be used in the absence of endometrial evidence. On laparoscopy, the positive finding for genital tuberculosis are the presence of tubercles. This topic again will be taken by Dr. Sunita Tandurkar Madam in great detail. Apart from that, an inflamed or blue uterus, unilateral salpingitis, oophorytis or tubo-ovarian mass, peritoneal fluid looking like blood, or caseation in the pouch of Douglas, perisalpingitis and orbital adhesions are also suggestive of tuberculosis. So when we put the scope, we see all these findings, and then we can suspect that there may be tuberculosis. And detection as a general rule, genital tuberculosis evades diagnosis mainly because there's a possibility nature of the genital tuberculosis. There's a low sensitivity of detection technique, and secondary nature of lesions. Infected organisms are sparse, and the lesions are usually bacteriologically mute. So this is the reason why sometimes we miss the tuberculosis, and patients who are suffering from infertility, they keep on getting the treatment for the specialist without the proper diagnosis of genital tuberculosis. The importance of genital tuberculosis is so that the treatment can be started before irreversible damage can have occurred, and it's an important cause of infertility. And we know that tuberculosis, it affects endometrium, it affects tubes, and when it has already damaged the endometrium or it has already damaged the tube, then the result, it's irreversible, and results are very, very bad. The treatment part I'm not discussing because it will be again discussed by the other speakers. So we know the standard regimes are there, and 6 to 9 months of treatment is recommended. Whenever there's a case of genital tuberculosis, we have to notify the government, and in the government setup, all these treatments are done free of cost. Now, what are the indications of surgery in cases of genital tuberculosis? The patient who are unresponsive or active disease in spite of adequate and anti-TB chemotherapy, or patients who are having tubercular pyosalpinx, or they are having ovarian mass, pyometra, or there's persistent menorrhagia of chronic pelvic pain causing deteriorating health status. But contraindications to the surgery are the presence of active tuberculosis at the extragenital site, or there is a favorable response to chemotherapy. So in that cases, one should refrain from doing any surgical intervention, and ATT should have been administered in full dose at least 6 weeks before surgery. So do surgery when after the dose is completed, do the surgery after 6 months of the completion of the dose. And in case of infertility, the conception, we all know that the conception rate in genital tuberculosis is very poor, and risk of ectopic is very high. Because the tubes are damaged, the fertilization takes place, but what happens is the embryo doesn't travel from the tubes to the uterine cavity because the fimbrial, cilia have got damaged, and this is the reason there are a lot of in a lot of cases ectopic pregnancy is seen in tuberculosis, and as already said, the damage of fallopian tube is permanent. And though tubal patency may have been restored, the tubal remains rigid and beaded in most of the cases. And in most of the cases, the patient, the menstrual symptom may return to normal also. So the alternative which we get in cases of infertility patient is the IVF. The role of IVF in patient with genital tuberculosis is now very highlighted, and many recommend without attempting tubal surgery because tube has already been damaged. Whatever you do, patency is maintained, but at times the conception is not possible. So most of the academicians, they prefer, they advise direct IVF in cases of tuberculosis, and success of the IVF depends on the extent of endometrial damage. Lesser the damage to the endometrium, higher is the chance of success. However, overall pregnancy rate per cycle in this patient is reported to be lower than those with tubal infertility due to non-tuberculous pathology. So thank you all for the patient listening, and thanks for the opportunity. Thank you.
Now I hand over the session again to Dr. Monica, madam.
I think Dr. Seema has joined, Dr. Seema Pandey. She was caught up in some emergency. So good evening, Nandita ma'am.
Nandita ma'am, good evening. Welcome.
Good evening. Welcome.
Nice talk, Manoj.
Thank you, ma'am. Thank
Very
you.
nice.
Very
So,
nice.
Dr. Seema, would you like to summarize Dr. Manoj's talk so that we listen to you also?
Sorry, I came in middle, but genital tuberculosis being something we always keep fighting between West and North India, that tuberculosis exists, genital tuberculosis or not. And the way Manoj has described everything, all those ultrasound signs and HSG and everything, we have to have a high index of suspicion as of looking at possibacillary status, especially in unexplained infertility patient, recurrent ectopic pregnancy patient. So I would like to say thank you, Monica, for involving me. And thank you, Dr. Nandita, for this session, these kind of session, and genital tuberculosis is one which is really very, very much needed.
Thank you so much.
Thank you, ma'am. Thank you so much. And good evening, Lakshmi ma'am. Lakshmi Shikand ma'am, welcome.
Good evening, Manoj.
Hi, Lakshmi.
Hello, Nandita. I'm just
Hi,
waiting.
Lakshmi. Hi.
Hi.
Hi, Nandita. Hi.
So can we have Nandita ma'am's CV, please? The tech team, Dr. Vishal.
Yes.
I am so honored and proud to introduce our ISAR president, Dr. Nandita Palshetkar, and we all take great happiness in wishing Madam and Pradeep sir a very happy anniversary today. And Madam has been President FOXI 2019, President IAGE 2017-18, Head of the Steering Committee Manyata Project 2019, AMOX President 2022, MOX President 16-17. She is the FOXI representative to FIGO, and she is also the FIGO project head of PPH AMP-LI. Member of several important government committees, including the State Supervisory Board of PCPNDT, Uterus Transplant Committee, ART and Surrogacy Bill, and the GOI Committee Midwifery Care in Childbirth 2019. She is the recipient of several awards, including Dr. B.N. Purandare Outstanding Service Award for the year 2021, Dronacharya Award for Exemplary Contribution Towards Gynecology and IVF, CSR Award, Inspiring Gynecologist of India Award, Doctors Day IMA Empowered Women Award, Femina Women's Super Award. And it's a pleasure to have you here, ma'am. Without your support, ISAR Perfection Series would have never started. Thank you, ma'am.
Thank you, Monica and Randhir. Fantastic job. I think I'm very happy with this series which you all have started along with Sunita. I think it's a wonderful, wonderful series, and the way you are spearheading it and pushing it. And today's topic, I think, wonderful. Genital tuberculosis, amazing topic. It is really required. And, for once I logged in early and I was able to, this excellent talk by Manoj. I mean, really, I think he was rushing through it. I don't know what you told him, whether to finish it quickly or what. He was really running like a Deccan Queen of our Pune Deccan Queen.
Yes, ma'am.
But really fantastic talk, and it is so good. And I want to tell everybody that genital COGS, the main important thing is early diagnosis. I think it's so very important for early diagnosis. We, as Seema said, our suspicion index has to be high. It really needs to be in our mind. And remember one thing, what I have noticed in my years of practice, 30 years of practice, is that now I'm seeing a lot of low AMH patients, and when we put the laparoscope in, we see it is due to tuberculosis. So I think when you have a patient of low AMH, it is very important to actually look for tuberculosis. And today you have all these tests, the PCR and the ELISA, which is very accurate. And, you can actually diagnose diagnose the tuberculosis. So it is something that's really wonderful. And the other point that I really I think you should stress on is the duration of the treatment. 6 to 9 months. There is nothing like a 3-month treatment in tuberculosis. It's very, very important to communicate to all our people that it is a 6 months to 9 months treatment, and that is the only way you can cure tuberculosis. I think it's so very important to spread this message. And the multi-drug resistant tuberculosis, I'm sure JB Sharma is going to address all of it. And I love what Monica's topic is, the panel discussion. I love the heading of your topic. I think rational treatment of tuberculosis. I think it's so important because anything and everything is treated under that topic. So fantastic job, and something which is often neglected by all of us. And we are not actually sure how to diagnose it, what to do. And it's a very, very common topic which we need to understand better, and the incidence is definitely high. So congratulations, and I'm happy that we have taken this topic, and the opening batsman has done a fantastic job. So congratulations once again, husband-wife team, and thank you for the wishes, everybody. Really, I think it's been a wonderful anniversary.
Happy anniversary.
Thank you.
Beautiful.
So it's been wonderful. 37 years of marriage with Pradeep, my God, and 5 years of courtship. So my God, it's like crazy. It's like really crazy. We spent a lifetime together. Okay, chalo. Thank you very much. And thank you,
so
Monica
much.
and Randeep.
Thank you so much, ma'am, and enjoy your day and enjoy all the years together, because you are a beautiful couple. And
Thank you.
I remember one thing about Nandita ma'am, she always say, Monica, I'm a happy person, I'm a happy soul. And that influence has rubbed off on me. So after Isar, I'm so happy, So Randeep is saying, why are you happy all the time? I said, okay, just because of Nandita ma'am.
I think all of us have plenty of reasons to be happy about. We are all blessed, and we should count our blessings. Yes.
Very true.
Good evening, Nandita madam, and wish you a very, very
Yeah, I
happy.
want to say hello to Lakshmi. I think she's really done a great
Hi.
job. And ICOG is rocking Lakshmi. It's doing fantastic well. And I've seen all your programs, and really happy that you're shining. You're completely shining. Fantastic job. Really superb.
Thank
And
you.
I think I can see Sneha
Nandita
also here.
ma'am, good
Yes,
evening. Yes, and
Yes.
wish you very happy wedding anniversary.
No. Yeah, I can see Sneha. Sneha, all the best in your elections. I think fabulous. I don't know who all are there for the elections, but all the best. I can't see
Thank you.
everybody over here.
Madam,
Definitely.
Dr. KD Nair is there from Delhi.
Oh, where is hi, KD, my
How are you,
counterpart.
ma'am?
How are you?
Oh,
Nice to see
fine.
you.
And Dr.
Yeah.
Professor Abha Singh is there from Raipur, madam.
Yeah. Hi, Abha. Hi.
Hello, Nandita.
So good to see you. I think welcome all of you all. This
you.
ISAR platform is always a wonderful platform, and this couple is really doing a fantastic job. So nice to see everybody.
Thank you so much.
Thank you.
Thank you. So I think with this
Nandita
wonderful
ma'am.
address and blessings from Nandita ma'am, we move on to session 2, which is a talk by Dr. Sunita Tandulwadkar ma'am. I hope because her mobile was switched off a couple of minutes back, she was probably giving a talk in the Haryana chapter of ISAR. So we will introduce the chairperson. I take pleasure in inviting our chairperson for session 2, Dr. Sneha Surendra Buyar ma'am, who is the chairperson Breast Committee FOXI 1921, Governing Council member ICOG 21-22, chairperson Medical Disorders Committee AMOX 22-24, founder president Vidarbha ISOPAP 17-19, president Yavatmal Obsgynae Society 2007-8, founder clinical secretary there, and executive committee member of AMOX. She is a keen investigator. She has done a lot of work in fighting against cervical cancer project, coordinator for Ankur project, research on menopause, research on cervical cancer.
Thank you. Thank you, my dear Monica. That should suffice. Thank you so much.
So much for joining us, Neha ma'am. And I take great pleasure in inviting our chairperson, Dr. Lakshmi Srikhande madam, who is the chairperson ICOG. Just now we heard about the wonderful work she is doing from the words of President herself. And she is the chairperson ICOG, Indian College of Obstetrics Gynecology, National Corresponding Editor Journal of Obs and Gynae, Jogi, National Corresponding Secretary Association of Medical Women India, founder, patron and president ISOPA Vidarbha Chapter 1921, chairperson IMS Education Committee 21-23, president of Association of Medical Women Nagpur AMWN 21-24, recipient of several awards like Nagpur Ratan Award, Bharat Excellence Award, Mehru Dara Hansotia Best Committee Award for her work as a chairperson HIV/AIDS Committee FOXI in 2007 to 2009. She has received letter of appreciation from the Maharashtra government for her work in the field of saving girl child. She's also held several important posts in FOXI and in her parent city of Nagpur. We welcome you, ma'am, for blessing us with your presence.
Thank you, Monica. Thank you so much for your kind words. I can't see Sunita. Has she logged in?
Madam, I'm just calling her. Till then, you can introduce her, ma'am.
Yeah, Sneha. Yes, very good evening, everyone. And at the outset, I would like to thank Dr. Sunita Tandulwadkar, madam, and of course, Dr. Monica Singh and Dr. Ranveer Singh for having me here. Thank you. A very good evening to all the esteemed faculties and seniors and mentors here. It's my proud and privilege to introduce Dr. Sunita Tandulwadkar, who is the head of Department of Chief of IVF and Endoscopy Center of Ruby Hall Clinic, Pune. And she's the advisor and consultant at D.Y. Patil IVF and Endoscopy Center, Pune. She's the founder and medical director of the Solo Clinic. She has got lots and lots of extraordinary achievement in her fields, and of course, India's first stem cell baby, and was first at the age of 45, that is 16th April 2018. Apart from her academic achievement and credentials, what I know as Dr. Sunita Tandulwadkar, in one sentence, I would like to describe that: a great academician, a skilled endoscopic surgeon, a very good human being, and of course, a leader whom you can look up to. With this few words, I would like to invite Dr. Sunita Tandulwadkar, madam, for her speech. Over to you, madam, for the speech.
Dr. Sneha.
I hope madam has joined.
Madam has joined. Ma'am, has she joined? Madam, Sunita ma'am has not joined. She is busy in another meeting and her mobile is coming switched off right now.
So we can
I
proceed with the
will
next
start
talk, yeah?
with the next talk by Dr. Jyoti Jaiswal. And when Sunita Madam wants to join, that time she can start her talk. So Madam, Chairpersons, if you permit, we can put the CV of Dr. Jyoti for you to present, please.
Dr. Monica, should we continue with the session, or you want to have the next chairperson?
Then we can introduce the next two chairpersons. I think Sunita Ma'am's mobile is switched off and she's not reading my messages. So she's probably. Yes. So I think we move on to session 3. Sneha Ma'am, with your permission. Lakshmi Ma'am, with your permission.
Yes, sir.
Thank you so much. Okay. Purnima, please.
Thank you, ma'am, for our next session. Yes, I welcome Dr. Anita Srivastava, ma'am, for chairing our next session. Ma'am is President of the Gynae Society, Bhopal. Ma'am is an alumni of Government Medical College, Jabalpur. And has done residency from GMC Bhopal. Ma'am is assistant professor at CMCH Bhopal and has been past vice president, secretary, joint secretary of Ops and Gynae Society Bhopal, past treasurer of Bhopal Menopausal Society as well. Ma'am has been trained in advanced gynecological laparoscopic surgeries, and she's senior consultant at Chirayu Health and Medical Private Limited, Bhopal, having a special interest in routine obstetrics, high-risk pregnancy, adolescent health, and cosmetic gynecology. I welcome you, ma'am. Thank you so much for joining us.
Thank you for kind.
And I welcome our next chairperson, Dr. Shabana Sultan, ma'am. She's professor in Department of Obstetrics and Gynecology, GMC Bhopal. Ma'am has presented many papers in national conferences, published many papers in national and international journals. Ma'am is member of esteemed team of PPH Bundle along with Sevagram, has been past joint secretary, Bhopal Ops and Gynae Society, past treasurer, Bhopal Ops and Gynae Society, president, and she is present secretary, Bhopal Ops and Gynae Society. Ma'am is an executive member of MCSR and has done various international projects along with Harvard University, and having a special interest in gynec oncology and high-risk pregnancy, and she is master trainer of cervical screening program. I welcome you, ma'am. Thank you for joining us.
Thank you, Purnima, for nice words.
Hello, Monica. I have joined. Whenever you say, I'll take my lecture. If someone else says lecture you started, I have no issues. I'll wait.
Madam, you can take over the mic.
Madam,
No, whose lecture you announced, Monica?
Madam, your talk
Your
has
talk.
hello, madam. Good evening, Dr. Sneha Buyar here, and we have already introduced you, madam, and you. I mean, we missed you at your introduction, so it's our pride and privilege once again to introduce you. I'm not going to read your CV. I've said that, and I've just said that. In one sentence, if I want to introduce Dr. Sunita Tandurwadkar, that she is a great academician, a very skilled endoscopic surgeon, and a very good human being, and of course, a leader whom we can look up to. So with this, I request you, madam, to start with your talk. Over to you, Dr. Sunita Tandurwadkar.
Thank you. Thank you so much. I had just another webinar and that's why I could not come, but I can see so many smiling faces. Lakshmi here to give the blessings, ICOG secretary. So it's a wonderful to have her on this platform. I can see Seema, Randir, Purnima, Jyoti Jaiswal, Monica, the shining darling, has to be there. And Dr. KD Nair, sir, kaise ho? Seema, huge congratulations for your most wonderful conference, which I missed thoroughly. And you have to make one more after my elections. Let me start with my talk without wasting much time.
Good evening, Sunita ma'am. All the best to you, ma'am.
Thank you so much. Thank you. Thank you. I think just give me 1 second to open up in another wing first, and then I will share it. I'm sorry. Yeah.
Yes, ma'am.
So, friends, I always feel that can I ask, my topic is endoscopy in genital tuberculosis, right?
Yes, ma'am. Yes, ma'am.
Yes, ma'am.
Yeah. Sorry. Advances in science. I always feel that the advances in science is always for the betterment of a human being. What is equally important in science is one has to modify and change one's idea as the science advances. Only then it will be possible for us to take these advances, may it in the medical field, may it be in a technological field, to use it to their best for our patients. Genital tuberculosis and infertility can be different in 21st century. We have the best of the speaker to talk about pathogenesis, etiological, and so many other things. So I will be restricting myself on how we can be innovative in managing this tuberculosis. We all know that endoscopy has given us the chance to be best for our patients in whatever best possible way. Now, when I'm talking about endoscopy, I'll cover laparoscopy part in a small and the hysteroscopy part, because tuberculosis affects the tubes and it affects the cavity equally. So it is responsible for up to 16% of cases in infertility, and infertility is seen in 50% of the genital cocks. High index of suspicion is required, especially in early stages, as untreated cases can cause permanent sterility. I will be showing you few videos how it happens. In subacute stage, what is important? You get congestion, edema, adhesions, maybe a miliary tuberculosis. This is a common picture. The moment I find all that, I know that I'm probably handling the tuberculosis in this patient. Sometimes we can see chronic nodules, swollen agglutinated fimbrias, rigid pipe-like tubes, and sometimes like pus, complete caseous tissue with the liver completely adherent with the Peutz-Jeghers syndrome. Sometimes you get disease. This is a chronic picture. Cox abdomen treated. Patient says, in childhood I had, or earlier I had, and now I'm not conceiving. And you need to be lucky when you enter in, because these are the patients where the intestine can be flattened, they can be adherent to the anterior abdominal wall, and you may go through and through this. So always have a habit of putting your telescope, another telescope in an accessory port, and enter and watch your primary port. It is a mandatory. Otherwise, you will cause fecal fistulas. These are very common. So I don't like usually to enter blindly in this patient. As I said, it affects fertilization and implantation both. Can you see these rigid tube? Sometimes people do HHG and they say tubes are open. Open tube doesn't mean they are functioning tube. Sometimes you can see that the tubo-ovarian relationship is completely altered there. The tubes are absolutely forming the adhesions all around, and this is irreparable damage. It's better that you take out this tube and move on with the function of a tube taken by the ART lab. These tubes either are non-functional, and if you tell patient, yes, I opened your tube, you will give them an ectopic pregnancy. Now, how it affects the tube, it also affects the implantation by two things. One, hydrosulfings. When they are open, they will cause a retrograde reflux in the uterine cavity, or tuberculous endometritis. Now, these are the tubes which are very swollen. One sided, this patient had ectopic and excision, and other side, can you see that? Now, in these cases, always open up the lateral pelvic wall. I will check where the ureters are. And once I confirm where the ureters are, I'll dissect down further. I will find where the ureters are, and then I'm just running it double speed, and then I will be excising that hydrosulfing so that I cannot cause a damage. Now, sometimes it is a frozen pelvis and hydrosulfings. You can't see the uterus at all. This band of adhesion, you realize sometimes patient says, I get pain after food and all because of this adhesion band. Now here, I'm trying to move the uterus and it's not possible. So the first energy source you will use is no energy source, and try and dissect. This patient she was a pathologist from Bhopal, and she had failed IVF. She had a huge right-sided hydrosulfings. And we are with Indore also today, and Bhopal group, MP group. This patient is a pathologist from Bhopal only. She was then advised surrogacy. She don't wanted surrogacy. One of my student was a fellow that time. It was her bhabi, and that's why she came down. And I realized her problem is not the failure because of a tuberculous cavity, but she had a huge hydrosulfing which was draining. Now, friends, these are all small loop of bowel. Can you see that? I removed lot of adhesion only with the scissor and all, but these are, you need to be careful. And can you see that? This is her hydrosulfing, and this was her cornu. With such a huge open hydrosulfing draining in the cavity, patient cannot have the consent. I don't like just to clip it. Clipping, fine, it may be easy, your job is, but why the hydrosulfings has happened? Because the terminal end, the femoral end is blocked. If you block the medial end also, it will form retort shape, huge collection over the period, and it will cause more damage. Hysteroscopy. Hysteroscopy in tuberculosis, you will find many varieties. Sometimes you will find that on sonography in a follicular phase, you never get a trilaminar picture. You always have, patient says, I had bleeding, I ceased my bleeding, and still you find echogenic. First thing in your mind you should think about is, it's not that her corpus luteum was working, it is because her endometrium is studded with this caseous tissue. Now, sometimes you can see there is so much of it can be look like a written products of conception. If the same patient, I will take it in the postmenopausal phase, I will say this may be the CA endometrium, but this turned out to be a tuberculosis for the patient. Now, sometimes the tuberculosis, can you go in and see? This may not be seen on sonography. It is only on a hysteroscopy. You can see early deposits of these. You will see that it is all pale endometrium. And this is a sign. The cavity is not getting distended very well. Tuberculous cavity don't get distended. While on the right lower, you will see tremendous vascularity. So on the left side, I have taken a pale endometrium picture. And while right side, I'm giving you complete red picture. It's an angry red cavity. And these are complete tuberculosis. Caseous tissue. Even on sonography, you will find that there is always thickening. These are the micropolyposis. You can see more than a micro, I will say macropolyposis, all these. So you have a different picture in different. Now, sometimes, can you see that? Only this small flimsy fiber, it should attract your attention. And that's why I say, always remember high index of suspicion. The right lower, I am not entered in the cavity. It was internal os closed. Case was referred for a Asherman. But you see here on a sonography, I found in a cervix a huge echogenic mass. So I wanted to go and explore what is that in a cavitatory lesion in the cervix for her. And can you go and see that? It is all the pus pouring out from there, the blood-stained caseous tissue. And this has created a cavity in the cervical canal. A very interesting case to work on. Now, this, why I always tell the patient or tell my all fellows, and I request even the gynecologists, never do dilatation and enter in the cavity pre-hysteroscopy. Use 2 millimeter office hysteroscope because many a times you may miss the finding. Now look at this. This is my fluid influx and these are the flimsy adhesions. This is a very early sign. Can you see it is just the stickiness? Now, if I would have dilated, this would have broken and I would not have come to know. Your hydropressure allows it to break. You don't even need the scissors in this. Just allow the hydropressure and you can enter in. Now, after entering, you will find flimsy adhesions there. And these are the early stages which you will miss if you do dilatation and a routine hysteroscopy. You may come out as a normal. But sometimes this case, same case, if I would have done maybe 2-3 years down, this is on right lower side. Can you see? These are all cervical folds and internal os is completely closed. Her cavity was okay. Can you see? Now what I'm going to do is I'm opening. Now here, these fibers are thick fibers band. Completely. You cannot just allow the hydropressure to go. You go little anteriorly or little posteriorly, you have in a perforation. Little laterally, you will open up nicely the uterine. Friends, believe me, you don't get oriented. Put huge intrauterine pressure, and that is causing cervical dilatation for me. The cervical folds all the time I'm checking, and I'm remaining in the center, and I'm cutting. Just have a patience. You can have a sonography sometimes and see whether your scissor is going in the direction of the cavity and not in the wall. You can do the sonography, control this opening if you are not very comfortable. Now, can you see? Now I know I'm going in a right plane, but there are still constriction rings and will not allow my hysteroscope. Instead of putting again the dilator, I can cut with the scissor and I break these fibers and then I will go in and then I will work in that cavity. So you have a varied picture of a tuberculosis with the hysteroscopy. There is no one picture, depending upon what stage you land in doing a hysteroscopy. Sometimes it is a pale endometrium, sometimes obliterated, sometimes the cavity is just not able to distend and it's not an adenomyotic uterus. You should think about all these. We have a lot of publications by Dr. J.B. Sharma saying that hysteroscopy and complication in COX and laparoscopy and complications in COX because of obvious reason which I told you. But if endoscopy, you do it carefully, it is a safe surgery in safe hands and you can do many more innovative things. Endoscopy gives us an opportunity to be innovative. Friends, I'm going to create this endometrium and I'm going to explain you how. This is another case, very old case of mine, internal os, just a pinpoint. Any good endoscopic surgeon can convert from internal os. I'm opening and opening all the time. I'm remaining in the center and a beautiful cavity is formed. Every endoscopic surgeon of the country will be able to do this job, converting the internal os into beautiful cavity. The problem is no one will be able to maintain just by estrogen and progesterone because this is such a fibrotic cavity that basal endometrium is damaged. And these are the cases where autologous bone marrow therapy, we know for years together, these publications for 1 decade now that is going mobilize those endometrial stem cells from the bone marrow and create it. And that's what we do in our solo stem cell. We do the autologous bone marrow derived stem cell. This is what I always love to do. Sit with the pen and paper and decide. I have a lab of my own. Frankly speaking, let me be honest, as an endoscopic surgeon or an IVF consultant, I don't think I would have entered into stem cells. Stem cell is a huge science, friends. Scientists have a knowledge, they don't have patient. We have patient, we don't have a knowledge. Some other degenerative condition, I entered into the stem cell. And when I entered, I realized that today we don't do only machineries, we have many methods to work on a stem cells. What is important is If you can create any organ with stem cells, why not? Because of some other degenerative condition, I entered into this regenerative medicine and I realized the immense power of a stem cell to perform its duty of recreation of a cells. The stem cells can divide into any cells, may it be hepatocyte, may it be osteoblast, may it be oogonia, and may it be a basal endometrium. The problem is in which cases it will work, we don't know. So this is a tuberculous cavity. We all know half partial cavity is obstructed. Endoscopy surgery and ART came to my help when I started stem cell, so that because of my endoscopy and because of infertility, I decided to create and work with the stem cells in the ovarian tissue as well as endometrial tissue. Now, I need to create the cavity as much as I can because I want to use the stem cell and make a bigger cavity. But at the same time, tuberculous cavities are small, so I should do fiber by fiber dissection. If I perforate, I spoil their entire obstetric career. So do slowly and steadily. Withdraw yourself time to time. And here I saw some hollow there, the black spot, and that's nothing but the opposite cornu. I was happy because of two reasons. One, it reached to my end stage of a making cavity. And second, I was thinking the internal os also will be fibrosed and closed behind this adhesion. It's pink. It's a hopeful cavity. But when I see now, it is a white cavity, complete fibrosed on right side, no vascularity, and on left side, it's a little pink. So we did some endometrial autologous bone marrow cell therapy. And then we put the patient on estrogen and progesterone and look at the second look, friends. First of all, what I see, again, I don't dilate. If you use a dilators, I would have broken this and I would have been under impression that I got a very good cavity, though I got it. First thing what I see is complete pink cavity. Second, I can see the corneal opening. Few flimsy fibers, but not the middle cavity is absolutely seen, and only flimsy fibers have come there. I'm damn happy with such cavity. I can cut few fibers and I can do second sitting of a stem cell. Can you see how the endometrial flecks are coming in? This is a magic which stem cells do. And unfortunately, why I can't tell every patient just do it, because I do have the patient where it has not worked. So we don't know which patient it will work and which patient it will not work. And that's why we still call it as a research. We should be very clear with our patient. We should be honest. We need to tell them, look, dear, this is probably the only remedy I can work. But I'm not sure whether it will help you 100%. It's research. We try. If it doesn't work, then surrogacy or adoption is your choice. But if it works, I can help you. Always under promise and over deliver should be your this thing. I'm cutting, I'm progressing, and I'll be doing it. This is frankly speaking, not my first case. The publication somewhere in 21-22 we did, but in COVID pandemic, this was around 12-13 case. COVID pandemic, all the data from different computers gone. Many fellows, I did not even see their faces. They came with the mask and went with mask. So we decided whatever the patient in front of you, consider as first phase and publish. If you don't publish, you perish. At 2035, I will not repent that I have not done my publication on endometrial regeneration. When more and more paper, by now I have several publication. And why this is important now for me? Because this science is lagging with the evidence. We don't know. We read others' publication and we gather our experience. And that's how we help each other in this stem cell field. About the PRP, just few lines. Thin endometrium is common. In 2017, probably the first publication from India about the PRP for the cavity and refractory endometrium, because we don't get vascularity in this patient. Sometimes we get only 3 millimeter, 4 millimeter lining with the sparse vascularity. You see, after the therapy, the vascularity improves. And that is the biggest advantage of PRPs in this patient. So sometimes if the patient can't afford thin endometrium, you wish to try PRPs, you can try. This was the first study so far, which had 68 cases in the world. Till that time, only 8 cases, 10 cases were published. Friends, we are what we repeatedly do. Excellence is then not an act, but a habit. I humbly request you all to help me to reach out this position of Foxy presidency. The elections are in August, from 1st to 10th August. You will all receive individualized link. Link cannot be transferred to each other, and ensure that it takes only 10 seconds to vote. Please vote. I like to thank each and every fellow of mine who helps me to be innovative all the time. Thank you so much. Thank you.
Thank you, madam.
Sunita is Sunita. You are a perfectionist, Sunita, and at ICOG also we are telling everyone to publish, publish, and publish. Howsoever small your work is, you can present it as a case discussion, a small case series, publish. And I'm so happy that you have published your work on stem cell, which is need of the hour. And I'm so happy to see your wonderful videos, Sunita. Whenever we give topic of endoscopy in tuberculosis, every speaker just covers the laparoscopy. I'm so happy that you gave equal time to histoscopy, because that is also very, very important, and it does affect so many aspects of that woman's life. Friends, I know Sunita since last more than 2 decades. She has come to Nagpur for so many workshops. So her passion for endoscopy is, I think, open secret. Everyone knows that. But what you all don't know is other qualities of her, that she's really humble, accessible. And I have seen on so many times that she has gone above board to come to the rescue, to come to the help of her own colleagues. And Sunita, I always appreciate that quality in you. You are really a great human being. Because first and foremost, before academician, you have to be a great human being, and that is what you are. And what to say about your leadership qualities, Sunita? Again, I have seen you leading so many organizations from the front. You are president for National IIG, National ISAR, Maharashtra ISAR, and I have lost count how many societies and associations you have headed. So you have that wonderful leadership qualities which a leader is supposed to have. So you are the best person. I wish you all the very best for your Foxy presidential elections. And your talk was simply mesmerizing with so many videos. You made it so simple for all the delegates to understand the histoscopy and laparoscopy findings in case of tuberculosis. Well done, Sunita.
Thank you, dear. I felt instead of taking that 20 minutes given to me, showing laparoscopy only, because as such, apart from removal of tubes, nothing you can do in laparoscopy. While in histoscopy, early diagnosis, the thinking that this can be a COX will help us to diagnose the patient and help her in a right time.
That is what I am appreciating. That is why I said Sunita is Sunita.
There can be nobody like Sunita, madam.
Sunita ma'am, our president Anita madam told the secret in the tuberculosis is timely diagnosis.
Yes.
So I think that was the main thing. Or madam, you have got so much qualities. Above all the qualities, it's a great human heart. So madam, you consider you are unopposed, because the great human heart is always above everybody. Thank you, ma'am.
Thank you so much.
Hearty congratulations, Madam
All
Sunita
the best.
Tandulwadkar, and I endorse everything whatever Dr. Lakshmi has said. And yes, for all of us, you are the best leader. So all the very best to you once again.
Thank you, dear.
Thank you, sir.
Thank you. Thank you. I'm really humbled.
And this Perfection series is just the brainchild and the child of Dr. Sunita Tandulwadkar. And because of her, we could take this series forward, which has been so well received all over India. And every time in this series, Dr. Sunita ma'am comes up with some brilliant topic with her own personal videos. Last time in genetics, she talked about her mother and how she treated chronic renal disease in her own mother using stem cells. Imagine the guts it requires to use a new therapy in your own mother. So, madam, you are an innovator and you are a very brave person. And for Randhir and me, you are unopposed.
Randir and you are the one who have, you who are taking this Perfection series. I'm too busy and I'm so thankful to both of you for working all and giving me the credit. Let me give the credit to you both equally.
Monica,
No, ma'am,
only a perfectionist can conceive this Perfection series. I know she is giving full credit to Randhir and Monica, but she is the brainchild behind this Perfection series, and only she can think of this Perfection series. Hats off to you, Sunita.
Yes.
Actually, we should thank Nandita also. Any creative ideas, she just says, okay, Sunita, you think they both will take care of this? Isar ka naam nahi hoga na. I said, nothing. We have a blind faith on both of them. And that's how na platform given to many more, the organization grow. I can see, Lakshmi, your ICOG series going on. Sometimes someone else is putting, someone else is putting, someone else putting. It means you have involved every academician in the country. Whether it is Charmila, or whether it is a Palani, or whether, every different person is putting in the group what they have done. And that shows that you're, taking everyone. Alone, you cannot do anything. You need to have 100 hands, more hands, more better Durga you will be.
Yes, ma'am. Yes, ma'am.
That is
Right
what
word used,
ICOG
ma'am.
is, and that is what, Sunita, you are doing in this series, taking everyone along with you.
Thank you. Let's move on.
All the best from our side. All the best.
Thank you. Thank you, Manoj. ये मनोज बात भी कर रहा है और ऑडियो ऑफ है. कैसे कैसे बात कर सकता है?
मैम दो जगह, एक ऑडियो के लिए, एक वीडियो के लिए.
Everyone, two screens.
Sunita ma'am will notice this.
I observe his audio तो on है but बात तो कर रहा है. Oh,
Yes, ma'am.
fine. Thank you.
Thank you, ma'am. Thank you.
Sunita ma'am will notice everything.
I remember Sunita ma'am was admitted in ICU and she was picking up our scientific sessions of my ISAR Bhopal, which we could not do. Salute to you, ma'am.
Thank you. Thank you.
Okay. So moving on to lecture number 3, session 3. Our chairpersons have already been introduced by Dr. Purnima. And we move on to the introduction of our speaker for session 3. Please, can the chairperson introduce?
Yeah,
Thank you, Monica.
Am I audible, Monica ma'am?
Dr. Jyoti,
Jyoti ma'am.
Yes.
Dr. Anita Srivastava will just say a few words about you and then you can proceed.
I wanted to confirm that I am audible.
First of all, I'd like to thank Dr. Sunita, Dr. Monica, and Dr. Randhir for giving me this opportunity. Now, I am introducing a very dynamic lady, Dr. Jyoti Jaiswal from Raipur. She is Professor and MD, Ops and Gynae Society, A&M Medical College, Raipur, 20 years of teaching experience. She is Vice President, Chhattisgarh ISAR. She is Vice President, Raipur OBGY Society, Secretary General, Raipur ISOP. She has got many awards, namely the Suvarna Khadikar Best Committee Award as a quiz committee chairperson of IMS 2021.
I'm just one of you, madam, between one of you all. Thank you so much for.
Madam, you are the queen of quiz, na?
Thank you so much
There
for
are
giving
many
me
awards in
that
the name.
brand.
NICA Award, the MS Signature International Award, Lions Club Shikhar Award, Chhattisgarh Medi Teacher Award, and she has organized many conferences like International SEPOM 2017, National MSCon 2017, 2 zonal conferences in 2014 and 21, of Indian Menopausal Society at Raipur. She has written book on quiz on menopause in 2021. She has contributed many chapter in Foxy and IMS publication, chapter in postgraduate textbook of gynecology by Foxy, and 30 papers in national and international journals. Madam, I
Thank you so
welcome you.
much.
Your
Thank you
topic
so
is
much,
very
Anita ma'am.
interesting. The imaging in genital TB, the eyes can see what the mind knows. As we all know, in spite of high suspicion of index, it is very difficult to diagnose and difficult to follow up the cases of tuberculosis because of the varied spectrum which it presents. So, madam, it is your turn to highlight how imaging can help us to diagnose genital tuberculosis and help us to treat it.
So, ma'am, is my screen visible?
Yeah, madam,
Yes.
make it full
Yes, it's
screen.
fine. Yeah.
Is it all right?
Yeah, start.
So first of all, good evening, everybody. And I'm so happy that I'm sharing this platform in front of all the stalwarts from all over the India. I give my best wishes to Sunita Madam. Dr. Nandita was also there. And thank you very much, Monica Madam, that you have involved me. And my respected teacher, Singh Ma'am is also there. My colleague, Dr. Manoj is also there. My regards to everybody, whoever present here. Hello, Sneha Madam. So this topic given to me, that is imaging in genital tuberculosis, where actually we get little confused that whether it is abdominopelvic tuberculosis, which we should consider, what is genital tuberculosis, what is pelvic tuberculosis. So the basically, if we divide, the abdominal tuberculosis is the tuberculosis of the gastrointestinal tract, peritoneum. It involves lymph nodes and or the solid organs of the abdomen. While the pelvic tuberculosis is basically the tuberculous adenitis of either the mesentery of the pelvic lymph nodes or without involvement of the genital tract. So if the genital tract is involved, then it will be genital tract tuberculosis. Otherwise, it will be pelvic tuberculosis if it is limited to the pelvic area. Peritoneal tuberculosis, also known as tuberculous peritonitis, involves the peritoneum of the abdominopelvic cavity. While the female genital tract tuberculosis, which incorporates features of all other things, basically it involves the female genital tract organs, the vagina, vulva, uterus, endometrium, fallopian tubes, and the ovaries. So directly coming to the imaging modality, because I know like JB Sharma sir is also there to give all about the overview, and Dr. Manoj has already talked about the genital TB infertility. So I will remain focused about the imaging part only. So, but the tuberculosis of female genital system is the disease which is one of the most difficult condition to diagnose with certainty. There are various imaging modalities nowadays present with us. They are being used in specific situations for the diagnosis. Coming to the old age thing, that is X-ray. So I would like to say that about 75% of the cases with active genital tuberculosis have a normal chest X-ray. So a normal chest X-ray cannot exclude the diagnosis of the genital tuberculosis, because the association of the active tuberculosis, pulmonary tuberculosis with the genital tuberculosis may be there, may not be there. So we should look for the pulmonary tuberculosis also if we get any sign for genital tuberculosis. Nevertheless, the genital TB, old heel lesions may be picked up by the chest X-ray. If even the active TB is not present, you can get some clue that if the old healed lesions are present on the chest X-ray. The third point is that the X-ray of the spine may show tuberculosis of the spine. It can show the cold abscess in the paravertebral area also. And during the evaluation of the infertility, certain findings in HSG may support the diagnosis of the genital tuberculosis. So here I want to emphasize that basically HSG is a good and simple imaging technique that can identify the lesion in more than 70% of the cases. So very typical, various kind of the features which are available, which are seen during HSG. The fallopian tubes is affected in almost all the cases where genital tuberculosis is present. But one important thing is that we should not go for HSG for the diagnosis of genital tuberculosis. Opportunistically, if any patient who is undergoing for the infertility treatment and investigations, and by that, if we pick up the HSG as a diagnostic tool, that's okay. Otherwise, if we are suspecting that this patient, clinical suspicion if we are having, that we should not go for the HSG to just see the confirmation. Otherwise also the histopathological confirmation or the cultures, they are the best thing to for the start of the treatment. So what we can find in HSG, a non-specific finding like hydrosalpinx, multiple constrictions along the whole length of the tube giving a beaded appearance. I will show you the pictures in coming slides. I am just summarizing here what kind of findings we can have. The most common finding of tubal occlusion, either it can be at the isthmus or it can be at the ampulla. So the ampullary closed pouch can be seen. The multiple occlusions with scarring, making the tube rigid and hose pipe-like and giving a pipe stem appearance. Even sometimes we can have the cobblestone appearance, gole aspas mein dikhai par sakte hai. Sometimes we can have the leopard skin appearance because of the some hypoechogenicity can be seen because of the caseous material depositions. We can have the tubal calcifications, even the golf club appearance where the bilateral distal isthmic obstruction is there and the rounded structure is seen like a ball, that can be there. Apart from that, the healing process may produce the dense tissue with scar around tubes, with decreased tubes motility and makes them fixed, causes peritubal adhesions also. The caseous ulcerations of the mucosa of the tube gives it an irregular contour of the diverticular outpouching surround the ampulla, giving is a tufted appearance kind of thing. The same process in the isthmic region gives the typical appearance of salpingitis isthmica nodosa, also known as SIN, and that is also a very pathognomonic for the genital tuberculosis. So these are the changes which we can see in the tubes, but there are other areas also involved with the genital tuberculosis, which can be depicted on HSG, like the uterine changes that may be appreciated in the HSG. Like you can see the signs of endometritis, and because of that, there may be intrauterine adhesions or asymmetrical cavity. Sometimes we think that how this asymmetrical cavity is there, but non-specific asymmetrical cavities are a sign of tuberculosis. A collar stud abscess is very specific. Tuberculosis T-shaped uterus, that is due to TB scar causing triangular uterine cavity, and it make it T-shape or septate appearance it can give sometimes. Sometimes we can just think that it is a bicornuate or a septate uterus, but basically it is a problem associated with the tuberculosis. The cavity is one, but it has divided because of adhesions. It is divided into the two. Pseudo unicornuate uterus, where one part of the uterus is almost obliterated, the unilateral obliteration followed by unilateral scar in the uterine cavity. The small uterine cavity with irregular contour, the complete obstruction of uterine cavity, sometimes like with gloved finger appearance. These all are quite suggestive of genital tuberculosis. And due to progressive endometrial lesion, contrast medium sometimes may pass through the lymphatics and venous system, and diextravasation to vascular channels can be seen. You can even see the pelvic node calcification during the HSG. So, CLEAN has given a diagnostic criteria for genital tuberculosis, where we can see if there is calcified lymph node or irregular calcification in the adnexal area. or if there is obstruction of the fallopian tube in the zone of transition between the isthmus and ampulla, if multiple constrictions among the pores of the fallopian tube, the multiple constrictions are there, if the endometrial adhesions and or the deformity or obliteration of the endometrial cavity in the absence of history of curettage, if the patient has not undergone the abortion and curettage, and even the endometrial adhesions are finding, then these are the diagnostic criteria for the genital tuberculosis. So first, to understand the normal HSG, we have to abnormal HSG and the TB findings. We have to understand the normal HSG, and this is a beautiful picture which is giving the normal, very nice, clear-cut outlining of the uterus, a very well-formed tubes giving a good spillage bilaterally. And now you see, these are the HSG pictures suggesting genital TB. In the first picture, you can see the pipe stem appearance. See here, the tubes are very convoluted and they are not straight. But here the tubes are like pipe stem. In the second picture, the septate appearance with the small cavity is there. Sometimes the person can understand, it is a septate uterus, and can go for the can think about that this is a congenital abnormality, while it is just infection. The third picture showing salpingitis ischemica nodosa, where beads in between you can see. Golf club appearance is being seen, gloved finger where the cavity is very small, and the last picture is showing the dye extravasation to the vessels. Like a rigid pipe appearance along with a septate uterus or a bicornuate uterus kind of presentation, which is not a septate or a bicornuate uterus, it is genital TB. And this in the angle, in the middle picture, in the angle, you can see a tobacco pouching appearance of the blocked imbrial end. And in the last one, a very typical cobblestone appearance, the third picture with the arrow, you can identify that intraluminal scarring is giving a picture of the cobblestone appearance. Sometimes the tufted tube, the golf club tube, the leopard skin, you can see the dark spots are there, and the beaded appearance very clearly is being seen. Indentation of the cavity due to synechiae, T-shaped tuberculosis in uterus, which we have seen in the earlier picture also, pseudo-unicornuate uterus. These all may be suggested of the tuberculosis. Now coming to the another very common modality, that is ultrasound scan. Actually saying the HSG is a most common type of imaging technique where we used to get the findings of tuberculosis, and by that only we identify that this patient is actually having tuberculosis. Otherwise, we do not send these patients for ultrasound and all, but we can find the adnexal mass in the adolescent girl, if especially if she is not sexually active and presenting with ascites. It is an indication that you should think about tuberculosis. The small uterus patients, we should think keeping the high suspicion of tuberculosis. If the atrophic endometrium, calcification in the endometrium, and incystal ascites is there. Incystal ascites is basically a very common feature with an advanced abdominal, pelvic, and the genital tuberculosis, and they are usually find in correlation with each other. Saline salpingogram or sonohistogram showing adhesions and tubal blocks are also suggested. So you can see that if we talk about the mode or which probe we should use, so basically they all are complementary to each other. There is not only transvaginal or transrectal ultrasound is important, but it is complemented by the transabdominal scan, because the combination of sonographic features gives you a better identification. Like you can see the endometrium better, endometrial findings better with the transvaginal but you can see the abdominal findings, matting of the lymph nodes, matting of the bowel loops. Those things can be seen better with the abdominal probe. So we should use the combination. Here, a very beautiful picture. The first picture is tubulocystic shape, which is just floating in the fluid. It is suggesting of abnormal hydrosalpinx, which is because of the tuberculosis. And sometimes you may not having the tubulocystic findings. So tuberculosis gives a very wide range of the presentations. Sometimes it will show the cystic adhesion, sometimes the fluid collection, sometimes the exudates, and sometimes a rigid pipe. Sometimes there is no collection at site, just adhesions, plastering. These kind of findings you can have. Sometimes you can have the exudative salpingitis where you will be finding pyosalpinx. Sometimes the ovarian tuberculosis along with the tubal, they both will combine, get adherent, and will be seen as the tubo-ovarian complex. So chronic granulomatous endometritis along with all these findings is suggestive of genital tuberculosis. And it can be it can found in a young lady, in unmarried, or the early married patient with infertility who are coming with the complaint of abdominal pain, in which you can find the complex adnexal masses, sometimes with normal OP, sometimes adherent to those. Sometimes you can see the scattered calcifications, which is highly suggestive of genital TB. The young adolescents with no sexual contact, specifically coming with PID, which is usually a common sequelae after the sexual contact, not before that. If they are presenting like that, then suspect genital TB. So coming to the tubercular endometritis, it is a very common presentation in female genital TB, and endometrial involvement is also very common, as we said that the tubal involvement is very common. So again, when as we have seen the different type of presentations in sonography about the adnexa, similarly the different type of sonographic spectrum you can see in endometritis also. You can see a thin endometrium, you can see thick endometrium.
Excuse me, Dr. Jyoti. Excuse me, Dr. Jyoti.
Yeah. Yes, ma'am.
I'm sorry. I think there is some background noise in your room where you are speaking from.
Just a minute.
Yes.
Excuse me. Okay. So
yeah, because there was a lot of disturbance while you were talking.
Okay. Actually, I'm out of my home, madam. I'm somewhere from outside. I'm presenting this, so trying to get rid of it.
Right.
Endometrial mass and pyometra can be present. May I request to have little less noise? Please, Jaya madam को बोलिएगा. Hello.
Thank you.
Hello.
Thank you. Thank you.
So the endometrial biopsy can suggest the suppurative endometritis. These are the supportive findings where we can see, sir, that these things we can get confirmed. And when we see the color flow, then we can identify whether it is a benign problem or it is a malignant problem. So tuberculous endometritis also is shown as the moth-eaten pattern of the endometrium. Tuberculosis of cervix can be seen as I have seen the patients with the tubercular cervix that they are we were confused like that this patient is a case of cancer cervix, but that patient was having with the repeated biopsy it was confirmed that it is having giant cell and it is some granulomatous disease, and finally confirmed as TB. So that is important to see. The tubercular peritonitis can be seen with the various modalities in three forms: the wet, fibrotic, and dry plastic forms. And according to the type, we can find the different things like in the CT scan or in sonography, we can have a different spectrum of the findings. So the moderate to massive amount of free fluid flocculated to ascites, which is often mistaken for an ovarian mass. Particulate ascites can be seen in exudative nature of TB, and wet ascitic fibrotic fixed with the abdominal enlargement that can be seen here. You can see the matted bowel loops along with the fluid. So these pictures are showing tuberculous peritonitis with fibrotic fixed pads. To summarize, the USG findings suggest suspect female genital TB when complex adnexal masses are there with identifiable ovaries with scattered calcification, moth-eaten appearance with fungating pattern, peritoneal thickening with pelvic blanket, and a high index of suspicion with complete history taking and physical examination cannot be overemphasized. Will not go in detail for the CT, MRI, and PET scan. Basically, the peritoneal tuberculosis and tubo-ovarian lesions have usually minimal findings on CT and frequently misdiagnosed with peritoneal carcinomatosis. MRI is useful for the diagnosis of theo lesions. Regular pattern of small nodularity along the peritoneum at MRI are helpful findings. All the advanced modalities are useful in diagnosing and evaluating theo masses. In spite of significant technological advances in imaging noted with USG, CT, MRI, hysterosalpingography, even remain the gold standard in evaluating the internal architecture of the female genital tract and fallopian tubes. So to gold standard, as I said, that HSG remains the gold standard, but for the pathological findings, we need detection of acid fast bacilli on microscopy or some biological specimen, histopathological detection of epithelioid granuloma on biopsy, and the important ancillary tests, including expert MTB, RIF, etc. Thank you so much, and I really sorry that I could not have a proper place to sit and present my presentation. So you all have to bear with the noises present here. Thank you.
Thank you, Dr. Jyoti. As usual, the presentation was wonderful, Jyoti.
Thank you,
and it was
Shabana.
enlightening, yeah. Because at times it's really very confusing to diagnose theo masses related to other causes related to tuberculosis. And I must agree with your comment that HSG is a gold standard method for seeing all the texture, internal diameters in all of the genital tracts. So I think it's a wonderful presentation. And any other questions to the audience, I think will be solved in the chat comments.
Yeah.
Dr. Jyoti, it was really a wonderful session, and you explained everything about HSG, the gold standard tarika of diagnosing genital tuberculosis. That was very nice.
Just wanted that we should not go for HSG for diagnosis of tuberculosis. Yeah. We just had an opportunistic opportunity, and this is the wonderful way where we can get the things.
But the films are preserved for a pretty long time, and we can get along many of the films of the HSG where the baby struggling with infertility and she has no cause. Every time she says it's okay, and then when we see the HSG report, it is something else.
Yes, really brilliant, Dr. Jyoti. Excellent pictures.
Thank you, sir. Thank you so much.
So over to you, Purnima, for proceeding further.
Yes, ma'am. I invite Dr. Ranveer Singh sir.
Yeah.
Yes.
Okay, thank you, Purnima. So now we are ending to the very important talk, and the next speaker is none other than the Dr. J.B. Sharma sir. Just first time I came to know that your initial name is Jai. So J.B. Sharma sir, so I'll call you J.B. Sharma. He will be the next speaker. And to introduce them, we have got the great person from the whole Foxy fraternity from the India. So first, Dr. Deepak H. Badge sir, and then Bhaskar Pal sir. So I'll just read out the CV of Dr. Deepak Badge sir. Can you present here? CV? Very nice to see you, sir, Deepak sir.
Hi,
And,
hi, Randeep.
Yeah, I think I
After-
remember you. I don't need your CV from the to read, but I remember
No,
I think
you don't-
you are.
Just a minute,
You-
just a minute.
Yeah,
you-
I think
Professor-
you are the from Jamnagar. Jamnagar is famous for Deepak Bagde sir, and just
No,
I came
no.
to.
That is why.
So
No, it's
sir,
fine, Randeep. Thanks for
yeah,
everything.
yeah. He's a past president SOGH, all Gujarat Gynics. Then he has got the gold medal in his during the PGs. Then his past positions are head of the Department of Gynec, MP Shah Medical College, Jamnagar, Scientific Committee Chairperson, Gujarat State Gynecological Societies, President Jamnagar Gynae Society, President Jamnagar IMA, Member Board of Studies of Saurashtra, and he has been given the SGOG Oration 2015, and till now he has delivered more than 62,000 babies. I'm very sure, sir, in coming years, you will cross the 1 lakh. So that is the boost because we have to do. And I'm always great admirer of you. और हम जहाँ भी मिलते हैं, इसी smile से सर हमेशा दिखते रहते हैं. And then I'll request you the next chairperson of the session, Dr. Bhaskar Pal, sir. He's very, very enthusiastic. We have seen him in the last Kolkata ICOG, then IGL and everything, endoscopy, any things. He has been a senior consultant from the Kolkata multi-specialty hospital. He's a chair AICC RCOG, immediately past president IH. Then Foxy representative to SAFOC 21-23. He was the organizing chairperson head under whom we have done a very great successful Foxy AICOG Kolkata, which because of Indore we could not do because of the COVID. Then immediate past president Bengal Ops Gynae Society.
That should be enough. Randeep, that's enough.
No. Vice President Foxy, and soon he will be our president in coming year to the Foxy. The platform is both of you, sir.
Thank you. Before anybody says anything, I think it's a pleasure to share the dais with Dr. Deepak Bagde. As Randeep, you said, Dr. Deepak Bagde is always smiling. Number one, he's a true Foxy friend. And if you see, every weekend he's traveling. So he's working 5 days a week. By working 5 days a week, he's delivered 62,000 babies. So which means on an average, he's delivered 8 to 10 babies per day, every day in the past few years.
Yes.
Bhaskar being a good friend, I'm sure you'll say good things about me, but it's blessings from friends like you and everyone that we are friends and we are meeting here. And thanks to Monica and Randeep to get us together. Bhaskar, what do I say about you? I mean, yes, I'll say everything about Monica and Randeep later on and the speaker later on. But first of all, let us be good friends, and I'm really happy that we are all good friends, Bhaskar.
Yeah. Sorry, I got disconnected. So it is a pleasure to share the dais with him, and it's also pleasure to listen to somebody who's not only a good friend. He's not only Jay, he's Jay Bhagavan Sharma, but JB is one of the most learned people in India, with enormous amount of publications in anemia and in tuberculosis. And I will request Deepak Bhai to formally introduce JB.
No, I think you said it all. A true academician. First of all, JB, yes, he said it rightly.
Thank you, sir. Thank you.
You are a true
After you, sir. After both of you.
I'm not saying anything about this part. You got all the accolades in your slides, and people know about that. I'll say just some personal things in the sense, a true academician and a very humble person. That says about it, JB. And I'm sure we are all eager to listen to how you manage tuberculosis. Like in my era, and probably your area earlier also, genital tuberculosis in a female genital tract, that means she had no babies or anything like that. Her fertility part was all over. Now, thanks to all these people here in ISAR and all the new modalities, we are at least giving them a chance to have a baby. So first of all, that is very important. I'm sure we are going to learn a lot from you in your next 20 minutes or so. Bhaskar, anything more you would like to add? Yes, JV, you can please continue.
Okay, thank you. Thank you very much. It's a real pleasure, sir. Deepak sir, Bhaskar Paul sir, and Dr. Monica, Dr. Purnima. Thank you very much for this opportunity, and I'm really pleased. And Dr. Jyoti did a wonderful job before me. She mentioned all about ultrasound, HSG finding, and all that will really help me. So, I mean, yeah. So we know, I'll straight away start because already everyone is getting late. So we know that tuberculosis, according to global TB report, we almost 10.6 million people are affected by TB and nearly 1.6 million death every year. And now MDR TB is also creating a problem for us. And India contributes actually almost 25 to 30% of that. So let's go straight away to our genital tuberculosis. And fortunately, genital tuberculosis is not life-threatening. So mortality will not happen that often, but it's a very important, as Dr. Deepak sir said, it's a very, very important cause of infertility and menstrual dysfunction. And it's not a new disease. Morgagni in 1744 described on postmortem examination in a 20-year-old girl who died of tuberculosis in that uterus and fallopian tube were cages material. And we all know that Robert Koch discovered the tubercle bacillus. So exact incidence of FGTB is not accurately known because many cases are underreported, and then many patients are asymptomatic, unlike like pulmonary TB where most patients are symptomatic. And we know that so nearly 30% of sputum positive pulmonary TB cases may have FGTB. So Dr. Tripathi and Tripathi, SN Tripathi, they did study from Odisha. They found almost 30% patient of sputum positive had genital TB along with on laparoscopy, and 10% of other extrapulmonary TB like lymph node can also have genital TB. And usually in India, the ladies are 20 to 40-year-old, though in the Scandinavian country and the European country, 40 years is the mean age. At AIMS, traditionally, sir, about 10% of infertility patients have genital TB, but at AIMS, the incidence is slightly higher because we get referral patients from like Odisha, Bihar, etc., where incidence is high. And in our IVF center, incidence of infertility FGTB was as high as 42.5%. So this is a little bit exaggerated because we get referred patients only. And even in AVB patient, almost 8% patient can have FGTB. So traditionally, we say that in USA, Scandinavian country, Europe, only 1% of infertile patients will have genital TB. South Africa, 4 to 8%. In India, it varies from 1 to 19%. Like in South India, incidence is slightly lesser, but higher incidence of up to 26% in AIMS, tertiary referral center. But that is false incidence because we get concentrated cases concentrated. Otherwise, in Delhi, also like in MEMC, it's about 10%. And I told you 48% in AR, assisted reproductive patient. We know that it is caused by Mycobacterium tuberculosis, but rarely Mycobacterium bovis also, because of unpasteurized milk, can cause it. And usually, I mean, the genital TB usually is secondary TB, secondary pulmonary TB. So very rarely it can be primary genital TB in 1 to 2% case from the infected semen of the male partner. So the male partner has got like this semen positive, which is very rare, then they can have. In that case, it will be cervix, vulva, vagina alone, as Dr. Jyoti showed in her slide of cervical involvement. So that can be in such cases, but otherwise normally it is secondary TB, secondary to pulmonary or extrapulmonary TB. So, and in that case, most common is pulmonary, but others like GI tract and all, because intestines are close by to us, that can also cause. And how does it separate from basically pulmonary and other areas is the hematogenous route, and from lungs, most common primary focus. And then fallopian tubes are the most common needles, earliest lesion being inside there. And then the tendency of bilateral involvement. That is sad actually, because then, bilateral tubal blockage will be there. And then other organs will also be involved. And then sometimes can be lymphatic spread also, like from abdominal cavity, and direct spread from neighboring viscus like tuberculous abdominal viscera. Some ileocecal lesion is very close to right fallopian tube, so it can come from that also. So it can happen. So almost in 95 to 100% cases, fallopian tubes are involved, but uterus is involved in about 70% cases. So this is important. These 30% patients where uterus is not involved, those are the patients which will be very suitable for IVF TT. Ovary is about 20 to 30%, cervix 5 to 15%, and uterine myometrium, vulva, vagina are 1 to 2%. So normally, like traditionally, we feel that TB has got symptoms, TB has got signs. But I mean, up to 12%, 11 to 12% patient of genital TB may not have any symptoms, asymptomatic. So it is unlike pulmonary TB patient where the patient has got symptoms as other TB, but these patients can be normal looking actually. That's so. Well, what is important that we should have it in mind that patient any patient of infertility or menstrual dysfunction can have genital TB. So you should think about that. But some patient can have fever with night sweat, but this fever will not be high grade. So it can often be misplaced and may just have a little bit of malaise, loss of appetite, weight loss, poor general condition. And menstrual dysfunction, especially initially when there are ulcerated lesions, then it will cause menorrhagia, postmenopausal bleeding. But usually after some time, most patients will come with oligomenorrhea, hypomenorrhea, or amenorrhea. Amenorrhea can be primary and secondary. And amenorrhea can be because of the involvement of the endometrium being eaten away by Asherman syndrome. But sometimes amenorrhea can also be as anti-gonadotropic effect of the tuberculosis. So in very severe patient of tuberculosis, anti-gonadotropic effect is there. So even in pulmonary TB, sometimes we can have amenorrhea, and that is amenable to treatment. Once TB gets over, so patient may have normal menses also. Then most patients have infertility, and primary is more common than secondary. Then they can have mass abdomen, but this mass is more of vague mass rather than typical of like if it's an ovarian mass, it has got a very well-defined contour. But in case of this tuberculosis tend to be more doughy feeling at vague mass. And then abdominal pain can be there, chronic pelvic pain can be there. Acute abdomen is usually secondary to pyogenic infection, secondary to this thing. And abnormal vaginal discharge, on speculum examination, I have seen it about 35 to 40% patients may have slightly excessive vaginal discharge of tuberculosis patient. Similarly, in signs, no signs can be there in about 10 to 12% patient, but patient may have mild grade fever. These people will not be 100 to 203, maybe just 100 or so, 99 or so. Lymphadenopathy in case of TB lymph node, crepitation on chest exam, as Dr. Jyoti was showing in an X-ray that up to 20% may have some chest X-ray finding. So same way, we should always auscultate it. Sometimes patient may have raised or bronchi, creps, etc. Then mass abdomen, I told you, vague or definite ascites, doughy feel of abdomen, and uterine enlargement, which can be secondary to pyometro or because of the tuberculosis. Then adnexal masses and induration is more common, tubovarian mass, fullness and tenderness in the pouch of Douglas. Rare signs will be hypertrophic or ulcerative lesions of cervix, vagina, vulva, which can be in primary genital TB or secondary also. And then labial mass. I have seen 2 to 3% of psychovaginal fistula, rectovaginal fistula, even in unmarried and non-sexually active girl. And then we took a biopsy from there because it looked necrotic and it grew, it grew epithelioid granuloma. And I gave her ATT and thinking I'll repair it afterward and have a guess. It just it healed of its own. So never do surgery in a case of tuberculosis causing VVF, RVF or enemas. First we treat it, and then if persistent is there, then only treat it, because many times even ATT can cure it. So I told you that, it's very important to keep the diagnosis in mind, because many patients can be asymptomatic and there may be no signs. So, but what is important is any family history of tuberculosis or history of anti-tuberculosis therapy in a close family member or past history of TB. So this is important, but sometimes the patient may not give this history because she has hidden it from her in-laws. So patient like an adolescent girl or when she was a young girl, she had pulmonary TB. But this information was not given to the in-laws family. So if we take them in confidence, I am not going to tell you, and then they come out, because we can really help them. So I'm seeing many of such girls also. And then general physical examination is very important for any lymphadenopathy. So I had 2 girls, at least one, she had tubovarian mass and non-sexually active. I was worried what to do. We can't do endometrial biopsy in unmarried girl, and I thought FNAC also would be. So I admitted her, and next day morning I saw her on the morning round. So there was discharging sinus from the left knee. And when we sent it for this thing, so it grew AFB. So she had like skeletal TB with genital TB. Another patient had lymph node in the neck. So we took FNAC from there. So if you do careful examination on all of the body, so there may be some other finding from where you can easily take biopsy or FNAC. So that is important. They can have abdominal TB, chest, and external genitalia, I told you, speculum examination, and of course, vaginal examination. And test will depend on the site of TB and its clinical presentation. Pawan is not going. I'm sorry. Next. So this will, which test is to be done. So traditionally, in case of endometrial tuberculosis, and if the patient is sexually active, because most patients are actually infertility patients, so then we tend to do endometrial biopsy for them. And endometrial biopsy sampling, we tend to take with now number 4 Carmen's cannula, and we take in the day 21 to day 24. So premenstrual phase. I just like some problem with the slide, I'm just sorting them out. So we do it on day 21 to 24, the biopsy, and we just, sorting them out again. Sorry, just some problem with the slide. And so,
Sir, we are also having this.
Okay. So madam, where we were like, because having some problem.
Can you run the slides, please?
Yeah, you can share from there, that also. I don't know, it's just not moving from here. So you can share from there, Dr. Purnima.
Yes, sir. Yes.
I'm going to share.
Yeah. So till they come, so I was saying that, so we do endometrial biopsy on day 21 to day 24 with the Carman's cannula, and we send the sample in saline for AFB microscopy, AFB culture, gene expert, and basically PCR. While the other part we send in formalin for histopath. Yeah. So if you can, yeah, we can. I mean, you can. I mean, yeah, fast forward, man. Yeah. Okay. Yeah. Okay.
Before
So,
that.
yeah. Okay.
Yes.
Okay. Yeah. So next slide, please. Yeah. So we'll next slide, please. Okay, so we know the index TB guideline. I mean, I was part of that, and Ministry of Health, they developed various guidelines in which, like, you know, we do endometrial biopsy basically, and we don't depend only on PCR. Next test, please. Next slide. Yeah. So basically, yeah. So single most important investigation is, I told you, endometrial biopsy. We send it saline sample for AFB microscopy, AFB culture, gene expert, and PCR. LAMP LP, you don't have to send for all if facilities are available, and formalin sample for histopath. But what I feel that at every center, AFB microscopy culture can be done. And, you know, and PCR. Alone PCR, we don't take into consideration. So next slide, we have already discussed. Yeah, we can go to the next slide. Yeah. So on histopath, actually, sometimes you can get TB endometritis or epithelioid granuloma, but sometimes even local lymphocytosis and all, I mean, can also be feature of that, like epithelial destruction, dilatation of gland, inflammatory exudation limon. But what I want to tell actually that to all of you, that you have a good friend in pathology department who has special interest in tuberculosis, and a friend in microbiology who has special interest, then the pickup rate gets higher. Those who are special interest in that, because even, like, you know, typical epithelial granuloma everyone will identify it, but you know, earlier cases can be difficult because ladies, because of menstrual, like every month menses are there, so the typical epithelial granuloma may not be formed. It is said before that, so that is important. Next, please. Yeah. So this, yeah. So AB smear we can see, but and culture can also be done. Next, please. I won't go into detail of that. Bacterial culture can be done, MGIT culture done. So depending on what your microbiologist use, we have to do one culture. Next, please. Yeah. So rapid culture method higher sensitivity, quicker results, 5 to 10 days, and they can also pick up like MDR analysis also. Next, please. Okay, and so PCR, basically PCR, many of us are doing it, and we are depending on also that, but it may have slightly higher false positivity rate. So only alone on the basis of PCR, we don't start the treatment because it can be high false. Next, please. Yeah, so this is the ultimate, I mean, the what a National Tuberculosis Elimination Program accept. One is the AFB microscopy, AFB culture, second, this thing can be done solid or liquid method, and rapid molecular diagnostic tech, which is CBNet or Gene Expert. And I mean, the newer ones are also coming, TrueNet and all, but we are still using Gene Expert. So any of the three are positive, then we also take it, and you can do drug sensitivity testing. Only problem is that it's very difficult to grow actually tuber bacilli from endometrial sample. So how to know the drug sensitivity when we can't grow the bacilli? But recently, I have actually published data on 6 patients, 2 primary pulmonary genital TB with the MDR and 4 secondary. And even last week only, I had a patient who in which endometrial biopsy grew actually. Gene Expert was positive and it was rifampicin resistant. So sometimes we are getting cases, but but it is difficult. Next, please. And so this is the order of preference. Basically, CBNet report or Gene Expert comes in 2 hours, but liquid culture may take up to 6 weeks, and solid culture may take even more than that. So we can depend on CBNet. Yeah, that is the first choice. Liquid culture second, and liquid DST is the third choice. Next, please. Okay. Yeah. Okay. This is just to show the slide. We are doing this LAMP also. Next, please. But LAMP and all. Next, please. I think too much. Yeah. Next. Yeah. Okay. So just next, because radiology has already been done. I'll not just quickly find. Yeah. Next, man. So just, I mean, already we have done that. Next slide, please. Next, CT scan, MRI. PET CT. Yeah, just go back to the PET CT for just, yeah. So PET CT, only role of PET CT is in the tubo-ovarian masses. And like, once we have given it can show us actually increased TB uptake, increased glucose uptake. So it can help, like Dr. Akesh Kumar, our professor of nuclear medicine, he can differentiate between ovarian cancer and, abdominopelvic tuberculosis by looking at the increased glucose uptake. It will be moderate in case of TB, it will be high in case of malignancy. But more important than that, I have found is that after after we have given treatment 6 months, 80 to the patient, after that still TO mass is persisting. Now, I don't know whether it is persistent TO mass or it is just fibrotic lesion. So PET CT may help in that. If the PET CT shows increased TB glucose uptake, that means there is still some remaining disease. If it is just like PET glucose uptake is not there, that means it's not there. So it can help in basically as an endpoint to stop TB ATT, or it can also show that maybe it's a case of MDR TB. So then you can try to do FNAC from there. So that may be the role of PET CT. HSG next, just quickly we can, because already shown the picture. Yeah. Now, so laparoscopy, I want to say laparoscopy is a very, very important modality, and we gynecologists are proud to do it. And like Deepak sir, Dr. Bhaskar, all of you are doing it. And it can, these are the various findings on peritoneum, cages nodule, tubular mass, hydrosalpinx, pyosalpinx, tubal blockage. Some finding which Dr. Jyoti showed on like HSG, they can be visible on laparoscopy also. Adhesion, NCC, as she showed. Next slide, please. Okay, and it can mimic actually ovarian cancer. So on laparoscopy and laparotomy, then we can, if you have opened the abdomen or done laparoscopy and it turns out to be tuberculosis, we don't make it a prestige issue that I have to do THBS or I have to do surgery. Just take biopsy, come out and put her on ATT. Because doing surgery is very difficult for these patients. You don't have proper planes and there is a risk of bowel injury. So there's no advantage, because ultimately you still have to give her ATT. Next, please. So next, please. I'll just show you. So these are the pictures I want to show you. They can be hydrosalpinx, congested fallopian tube. Now, some of these pictures may be seen in chlamydia, mycoplasma, PID also. But this patient had infertility. She had oligomenorrhea, and then she had positive PCR. PCR can be used as a basically screening method to do laparoscopy, but not alone. And then we found this patient that she had hydrosalpinx, congested tube. So we took it as a probable TB. Next, please. This patient had cages nodule. This is and look all around 360 degree, not only in the pelvis. This is gynecologist. We have the habit of just looking only at the uterus tube ovary. Please look 360 degree all around. They can be finding in the abdominal cavity. Sometimes they can be finding in the liver, perihepatic adhesion. I'll be showing you. So in this case, you can say frozen pelvis is there and there are cages nodules, very specific of tuberculosis. Next, please. Okay, adhesions are very common. Adhesions are very common in these patients. They can be in the perihepatic area or tubal areas. Next, please. And they are vascular, they are bleed. So don't try to cut them because they are reforms. And so this is the perihepatic adhesion, fissure cuttings. They are very common. We found in almost 40% cases. So when you do a laparoscopy for tuberculosis, please do look all around. Next, please. Again, cages nodule on the omentum and on the peritoneum. Next, please. Again, there's a cages nodule in the pouch of Douglas, hydrosalpinx, and you can see adhesions and block tubes. Next, please. This is a patient, you can say it's endometriosis, but along with this patient had tuberculosis also. So I want to highlight, normally if we diagnose endometriosis, we rule out TB and vice versa, but some patient can have both. So she had histopath proven and endometriosis as well as TB, so then we gave her treatment for both. Next, please. Okay, this is a angry looking uterus, but this can be not specific of tuberculosis, probable TB, because she had positive PCR, she had infertility, she had oligomenorrhea, and this like angry looking uterus and tube because of increased vascularity. So then, but it could be seen in case of chlamydia, mycoplasma also. Next slide, please. Again, convoluted tube, not specific of tuberculosis, but she had other findings, so we took it as a probable TB. Next, please. Again, this I just wanted to show you hanging gallbladder sign because of the, this liver gets adhesion to the anti-abdominal wall because of perihepatic adhesions. And in the lowest slide, you can see cages nodule of TB and hanging gallbladder. Next, please. Again, this is the, blue python sign. Even today I was doing a laparoscopy. So if you put the dye, like Dr. S.N. Tripathi was telling me that if you put a dye, normally in case of normal patient, it just flows. But in case of tuberculosis, it will fill the fallopian tube, and fallopian tube will get distended like a blue python. And later on, if you keep on watching it for 1 to 2 minutes, it ultimately goes also. So the tube becomes. Today I also did case. I didn't show the picture just now. So she had typical of this. So this is case of blue python sign. And this is a very beautiful picture. If you see published in Jogi, you can see cages nodules, very specific of tuberculosis. Plus both fallopian tube got fused to each other. So just like a kissing ovary sign there in case of endometriosis, this is kissing fallopian tube in case of tuberculosis. But unfortunately, prognosis for fertility is going to be poor. Next slide, please. And this is the apart from perihepatic adhesion, I saw ascending colon, lower 2/3, upper 1/3 junction, 5 to 4 centimeter adhesion is there. And this is probably on the right side adhesions are there. It is probably because ileocecal region is more commonly involved. And by the time you go to transverse colon or descending colon, then that area is better. So it has implication that when you put the second port, don't put it in the right side. There is the risk of injuring the bowel. But on the left side, we can put after observing. Next, please. Yeah, again, already Dr. Jyoti showed it, like the shrunken cavity. So it looks like dry tree branch, fallopian tube sign. And when we did laparoscopy in the same patient, they were, next, yeah, you can see those were the cages looking tube, just like as if they're dead tube, not like dry tree branches. So it can be bilateral or unilateral. And then this parachute sign, next slide, please. Yeah. So this also, yeah, if it's ascending colon, you can say this is adherent to the anti-abdominal wall in case of tuberculosis. Next, please. Same picture on higher magnification. You can see, can you see the cages nodule on that? So this is, if I put the second port on the right side, I would go through the ascending colon. So that's why whenever you put the second port, do it under the under direct visualization. Otherwise, you can injure the bowel, and it's better to put on the left side, because left side, by the time disease dies down on the left side, so left side chances of adhesion are much less. Next slide, please. Yeah, and then the sigmoid colonic, again, in the lower pelvis, sigmoid colonic adhesive band can be there, but descending colon is usually free. Next slide, please. Yeah. Okay, this is the descending colon adhesion, you can say. Next. Okay, again, same descending, yeah. And these are the other, like, basically there are other adhesions in these patients. Compartment sign is also there. Next slide, please. Yeah, this is again compartment sign and, colonic adhesion. Next, please. Okay, yeah, this is the, like, as nature tries to compartmentalize tuberculosis in the left lower segment, right lower, like that. But it can be sometimes, more advanced also. Next, please. Yeah, this is what the algorithm we published. Next slide, please. Yeah. Okay. On hysteroscopy, again, you can see that, cavity becomes small, shrunken, cavity becomes pale in color, and you can see the cages nodule. You can see grade 1 to 2, 3, 4 adhesions also. Next, please. Yeah, you can. Next. Again, these are the grade 3B adhesion. So this has implication grade 4 adhesion, that even after ATT, these adhesions are persistent. So unless there are grade 1 to 2 adhesion, which you can easily cut by hysteroscope, the chance of even IVF ET will not be there for grade 3, 4 adhesion, because in spite of ATT, they may persist. So next, please. Yeah. So again, same thing. Yeah. Next, please. Okay. But what I want to highlight, there is increased risk of complication on laparoscopy and other surgeries in case of tuberculosis because of poorer planes. Next, please. Okay. And yeah, so but what we do after end of 6 months of ATT, then I do laparoscopy, hysteroscopy on these patients. That will be important, because if at the end of 6 months, if the on laparoscopy tubes are patent, ovaries are fine and endometrium is okay, then she can try normal IVF, normal conception with the ovulation induction. If tubes are blocked, but endometrium is receptive, then she can go for IVF ET. But if tubes are blocked, endometrium has got more than grade 3 to 4 adhesions, which can't be cut, then she goes for surrogacy, provided ovaries are normal. If ovaries are also gone, I have seen 2 to 3% patient ovaries are also dead, because tuberculosis eats away ovaries also, or very poor ovaries, then they go for adoption. So that is basically a repeat laparoscopy and hysteroscopy can prognosticate the patient. Next, please. Okay, and treatment regimen. Next, please. I'll just show you. So yeah, just, you don't have to remember it, but basically grossly, we can give RHZD daily for first 2 months, and then RHE daily for next 4 months. You can refer the patient to DOT center, and what I write, like, laparoscopic evidence of genital tuberculosis, category 1 ATT to be given from and refer to DOT center. I put my sign, signature, stamp. Then they have to give. So patient can get free medicine from DOT center, and she is given 500 rupees per month in Prime Minister's Poshan Yojana also. And we had to register all patients, so they will do for you. So registration also done. So we are in a plus for this thing, and these are the quality assured drugs. And if next slide, please. This is beyond the scope, but drug resistant TB can be rarely there. Then in that case, refer the patient, and they receive basically 18 to 24 months longer drug regimen, which we will not discuss today. Next, please. Okay, so this is, most patient will tolerate ATT safely, but little bit derangement of liver enzyme can be there, little bit like loss of appetite can be there, but most patients tend to sort it out. Ask them to eat good nutritious diet. Next, please. Milk, egg, non-veg also they can take along with ATT. So this I already said, surgical treatment we usually don't do. They are high complication rate. But I told you that no. But if there is any abscess, that can be drained. And next, please. Yeah, this is the patient I opened for ovarian cancer. Turned out to, you can see the cages material coming out, and you can see how everything was adherent there. If I pursued to do hysterectomy and all, I would have injured the bowel. So I just came out, gave her ATT, and she ever since better. Next, please. Okay. So this I'll finish in next 2 minutes. So assistive reproduction is very useful, I told you, especially if the tubes are blocked and endometrium is receptive, or grade 2 to 3 adhesion less than that, which can be cut by hysteroscopy. Next, please. And these are the most publication coming from that. Almost 25, 30%, 35% we at AIIMS we are getting results. I don't do IVF, but my colleagues do. After, but give them antituberculous therapy for full 6 months. That will basically cure their endometrial tuberculosis. Plus, that will increase the blood supply to the endometrium. If the patient actually gets pregnant during that time, then either there will be implantation failure or there will be abortion. So it's better to complete 6 months course of ATT, then do embryo transfer. I have seen quite a few patients thrice ART failed and all. And when we gave them ATT after that, I mean, it was successful. Next, please. So this is my last slide, basically flow chart. So whenever you get a suspected case of TB, do endometrial sampling for that. And a composite reference standard is nothing but combination of the test. I mean, history taking, examination, endometrial biopsy, ultrasound CT in some patient, and laparoscopy. So I usually combine endometrial biopsy and laparoscopy. See, for endometrial biopsy, the patient has got AFB microscopy, AFB culture, histopath, gene expert. Straightway TB, no need of any other test, give us treatment. Definite TB. If only PCR positive, then we don't treat it. But if PCR positive with ultrasound, CT, MRI finding, then probable TB start treatment. Positive PCR or other evidence, and then we do laparoscopy. On laparoscopy, we can have definite finding. Definite findings are only 3. Cages, nodule inside I showed you. Then these, tubes which are basically kinking tubes are there. And so these are, basically, so 2 or 3 signs. They're definitely, otherwise probable finding like perihepatic adhesion, peritubal adhesions, saggy areas. Tuberculosis is a definite sign. So those with basically patient is infertile, patient has got oligomenorrhea, patient has got positive PCR, some C has got adhesion. So then I'll take it as a probable TB and start treatment. But if laparoscopy is totally normal, hysteroscopy also you can get, basically adhesions, you can get, cavity, saggy areas, tubercles, adhesions and all. So they are probable TB. And then you can start ATT. But if laparoscopy is normal, hysteroscopy is normal, only PCR, then we don't start them TT. So like that, I mean, most patient can be sorted out and they can be referred suitable. So at the end of the therapy, I mean, patients may cry that if suppose, so the tubes are patent or and endometrium is fine, they can try normal conception or ovulation induction. Tubes blocked, endometrium fine or grade less than grade 2 to 3 adhesion, cut them and then IVF ET. Tubes gone, endometrium also gone, then they go for surrogacy. Probably ovaries are normal. If ovaries are also gone, very rare, then patient can go for adoption. So at least we have prognosticated them. I may not be able to give them baby in all, but at least I speak to them, don't sell your house, don't sell your land, just adopt a baby or try for surrogacy or like that. So they cry, but there's no point in unnecessarily giving them false places. So thank you very much.
Yeah, wasn't that wonderful? I told you earlier, he doesn't require an introduction. His words are going to say a lot. Maybe that was wonderful with a wonderful collection of the slides. The only question is, previously, I don't know how far it was true with you people or the other people here also. When I used to find a laparoscopy in a normal, absolutely with no symptoms and tubes blocked, we used to do endometrial biopsy. In quite a few, in fact, with no laparoscopy signs also, we used to find endometrial biopsy showing the genital tuberculosis. Fortunately, the trend is really decreasing down the lines, and probably I just say about 1 or 2 now. Previously, probably we used to see about almost 20 a year or so. And I'm sure it must be with everyone. Yeah. At least the obstetric career, we used to think that it's over, but not now. Yes, thanks, sir. Monica. Thanks, Ranveer, for getting me into this. It was wonderful. Purnima, thank you very much.
Thank you, sir. Thank you. You are my elder brother, sir. Thank you.
Yeah, JB, you have been a good friend.
I really thank you, sir.
JB,
It was a very nice
Hi,
lecture.
Bhaskar.
Hi, Monica. Before you wrap up, JB, I have a question.
Yes,
you've told us how to diagnose tuberculosis. You've given us a wonderful flow chart, how to prognosticate and manage. Now, I just wanted your opinion on a lot of people are doing well as a part of routine unexplained infertility investigations, a menstrual blood TB PCR. They usually do a RNA PCR. I just wanted your opinion on that. How logical is that?
No, actually PCR, national anti-EP is against PCR being used. But the only indication of that is, in fact, I reviewed a paper from European journal, Janesh Gupta sent it to me. So only role is in unmarried girls. Suppose you have got an unmarried girl, non-sexually active, where we can't do endometrial biopsy. In that case, and you have high suspicion of high index of suspicion of tuberculosis. So in that case, the only indication of doing a menstrual blood, because pickup rate of menstrual blood is very poor, and menstrual blood picking up AFB microscopic culture is very, very rare. But only PCR positive is not actually accepted by NTEP or by
So which means that if it's
patient, you can do not routine. It's selected.
Which means that in infertility patient, if we suspect tuberculosis of the endometrium, we should send an endometrial sample for AFB culture.
Absolutely.
And not a menstrual blood.
That is
Thank you. That is the message I needed. Thank you very much.
Thank you.
Monica, over to you.
Thank you so much, our chairpersons for the session, Dr. Deepak Bhagre sir and Dr. Bhaskar Pal, who are such good academicians and legendary figures in the Indian gynecological scene. We are blessed to have you. And Professor J.B. Sharma, I can only dream about your level of work. I mean, we put flyers all over MP, Gujarat, Chhattisgarh that Professor J.B. Sharma is speaking. Please listen. Because the legendary Dr. J.B. Sharma is speaking. I mean, your name, Jai Bhagwan Sharma, means, I mean, you are Bhagwan of tuberculosis. For last 7 days, because of Purnima's motivation, I have been just reading your 7 tuberculosis because I had to conduct a panel after your talk, and I wanted everything to be everything. And sir, I would suggest everybody to read sir's articles, the NTEP guidelines, the standard treatment workflow sheets, and the current recommendations if we have to eliminate tuberculosis from our country by 2025 or 2030, according to the vigor and the enthusiasm that the government wants it to get eradicated. Thank you, sir.
Thank you, ma'am.
Thank you so much.
I thank you for inviting me, Dr. Purnima, as well as you, madam. Thank you very much.
Thank you, sir. Thank you so much.
So can I leave now? Thank you.
Thank you, sir. Sir, we will trouble you again soon.
Anytime, madam. It's a pleasure. It's a pleasure. I'm on that.
Thank you, sir. Thank you, sir. Thank you. Many thanks, Bhagre sir. Many thanks, Bhaskar sir.
Thank you very much.
I hope you are staying for the panel discussion.
Monica, I've got some OPD questions. As soon as I finish them, I'll join you.
Okay, definitely. I think Dr. Randhir was there, or he has deserted us. So is Shabana there? Shabana? Dr. Shabana, are you there? Okay. So,
Yes, she's there.
Yeah, Dr. Shabana, can you introduce moderators for the panel discussion, please?
Yeah, can I get the CV slides? So we are now starting with a very interesting panel discussion, and moderator for the panels is Dr. Monica Singh and Dr. Purnima. Dr. Monica Singh is a very well-known personality of Bhopal. She is an infertility specialist. She is working as a professor in Allen Medical College, Consultant Reproductive Medicine, Bhopal Fertility Center. She is presently Vice President, Bhopal OB-GYN Society, past Honorary Secretary, Bhopal OB-GYN Society.
That will be all, Shabana. That will be all.
She to have created lots of many awards. The next moderator is Dr. Purnima, very active personality of Bhopal Obstetric Gynae Society. And for today's webinar, the credit goes for maximum effort to you, Purnima. And I think she is also having a very nice CV with all the training in gynecology and various awards, various publications to her credit. So over to you, Dr. Monica and Dr. Purnima, for starting this great panel discussion. Thank you.
Thank you so much for the introduction, Dr. Shabana. And despite your busy schedule, you could be here. I'm so thankful to Dr. Shabana and Dr. Anita for staying with us all the 2.5-3 hours. And we now have the practical problem. After listening to the stalwarts, after listening to evidence, after listening to guidelines and experience, images, CT, MR, ultrasound, now we have cases for you, specially compiled for our panelists to give their opinion if such a patient comes to your clinic with or without reports, with or without history, hidden history, history hidden from in-laws, How will you tackle rationally, logically, humanely, and without any errors? So I invite the panelists. Can I have the first slide? The first panelist is Dr. Palak Gowri, a very dear friend who is from Gowri IVF Center, Raipur. She has a vast area of experience in obstetrics, gynecology, ART, laparoscopy, has been working since 27 years and running a state-of-the-art IVF center which provides high-quality healthcare, which is safe, effective, and patient-centered. Welcome, Dr. Palak.
Thank you, Monica. Thank you for the introduction, and thank you for having me here on the wonderful platform with such dignitaries.
Thank you, Palak. Next, we have on the panel Dr. Tabassum Dalla. Has she joined, Purnima? Has Dr. Tabassum joined? Because she apologized, she is in another webinar. So we proceed to the third panelist.
I can't see her, ma'am.
Dr. Monica Pathak also had apologized. She had some problem, some function to attend in the family. I think we go to the panelist number 4. Yes, Dr. Vinita Singh is there. Madam.
Yes, ma'am, I'm there.
Welcome. Welcome, Dr. Vinita Singh. She is additional professor obstetrics and gynecology at All India Institute of Medical Sciences, Raipur. We already have seen a brilliant personality from AIIMS Delhi. So now we'll see another brilliant personality from AIIMS Raipur, which are state-of-the-art institutions of India. And admittedly, they have the best resources, the best facility, they train the best minds under the best faculties. She is fellow and faculty ICOG, secretary of IAGE chapter of Chhattisgarh. Her special areas of interest are high-risk pregnancy, obstetric emergencies, infertility, endoscopy surgery, and cancer screening. She has received her infertility training from Maulana Azad Medical College, Delhi. She has fellowship in Women Health Initiative, training program on gynecological endoscopy. She is FMF UK certified uterine artery Doppler sonologist, along with cervical length assessment and Doppler ultrasound. She is also certified in ultrasound in pregnancy by FMF India and FOXY. She is an avid academician who has presented several papers in gynecology, endoscopy, and she is the reviewer and editor of Index Obstetrics and Gynecology journals. Welcome, madam.
Thank you, ma'am, for your kind introduction.
Next, we welcome Dr. Prakriti Verma, who is Director Vardhan IVF ICSI Center, the first IVF center of Bilaspur, Chhattisgarh. She is a consultant infertility specialist and laparoscopic surgeon, Care and Cure Super Speciality Hospital, Bilaspur, ex-consultant of Wockhardt Fortis Corporate Hospitals, Mumbai. She has advanced diploma in ART and reproductive medicine from Germany. She is the current secretary of Chhattisgarh chapter of IFS. And we were so proud to have KD Nair sir on board with us a short time back. She's also organizing secretary of the CGIFS Conference 2022, secretary of FOXY BSP 1516, member of IMA and Gynecologists Association of India. She has the distinction of producing the first ICSI baby and first ICSI twins of Bilaspur, invited faculty in various national conferences, Yuva speaker on the topic of PCOS, presented her topic on CA cervix, and has been faculty in various conferences. Welcome, Dr. Prakriti.
Thank you so much, ma'am.
Purnima, you can introduce now.
Thank you, ma'am. So now I welcome Dr. Pragya Suryavanshi. Ma'am has been invited as faculty and speaker in many national and international conferences. She has presented many papers in national conferences and has been ex-consultant GRMC Gwalior, GNM Medical College Raipur, and GMC Nagpur. She has received Women Recognition Award 2018 and is a member of FOXY and past treasurer FOXY Gwalior. She is Joint Secretary SAR Chhattisgarh chapter, member of IMS ESHRE, and has received Best Paper Presentation Award IMS 2020, Best Poster Presentation Award ISAR 2022, and is having a special interest in high-risk pregnancy and artificial reproductive technology. So I welcome you, Dr. Pragya Suryavanshi, ma'am.
Thank you, madam, for nice.
Thank you for joining us. So our next panelist is Dr. Ritu Jain, ma'am. She is MS Gold Medalist and she is Associate Professor, RIMS Medical College, and Director, Consultant, Laparoscopy and Fertility Expert, Sri Mahavir Hospital, Raipur, Chhattisgarh. Ma'am is very good academician, and she is Secretary, Raipur Menopausal Society, Executive Member of Raipur Menopausal Society and Raipur Foxy, and has been organizing committee member of various national conferences. She has been invited as faculty at various national and state conferences and has many poster, paper and quiz and debate awards into her credit. She has 6 original research paper and 5 case report published in various international and national index journals. I welcome you, Dr. Ritu Jain, ma'am.
Thank you, Dr. Purnima, for that introduction.
Thank you for joining us, ma'am. Now, our next panelist is Dr. Anuradha Tibrewal Chaudhary, ma'am. Ma'am is consultant in reproductive medicine at Nova IVF Center, Raipur, and is an alumni of SCB Medical College, Cuttack, and has done fellowship under the guidance of Dr. Purnima Nadkarni, ma'am. She has done certified course Crest, Singapore, and has done diploma from Dubai and Born Hall Fertility Clinic. She has been awarded with the prestigious CS Down Award in 2010 for the best paper presentation and has received the Best Paper Award in Critical Care Ops Conference 2017 and has various publications in national and international journals. And she has authored many chapters in various books also and has experience in managing all kinds of infertility cases and handling many cycles of egg donation and surrogacy as well. I welcome you, Dr. Anuradha Tibrewal Chaudhary, ma'am.
Thank you for nice.
So any faculties who are still with us among the speakers, Dr. Jyoti Jaiswal ma'am, Dr. Manoj Chelani, Dr. Shabana Sultan, Dr. Anita Srivastav ma'am, Dr. Lakshmi ma'am, please feel free to join the panelists with your expert comments because these cases will require all the suggestions from all the stalwarts over here. So this panel is open to all. We proceed with the panel discussion. Dr. Purnima, can you start the slides, please?
Yes. Ma'am, I'm not able to find the option of a screen share.
Dr. Vishal, technical support, Mr. Ronak, can you please?
Yes, ma'am.
Can you please help Dr. Purnima in starting the slides? She's
Sure,
not.
ma'am.
Yeah.
Sure.
Yes.
Now is it visible?
Yes, full screen.
Okay.
This panel discussion is entirely due to the hard work and perseverance of Dr. Purnima, and I must admit she's a very, very hardworking girl. I think I was hardworking, but Purnima is Monica into 3. So, so we have a long way to go. So, and she has sat till 2:45, 3 a.m. to prepare these slides, and every day she's discussing tiny things. Madam, is case mein aisa hona chahiye. Madam, this is where, you know, they will question us. So hats off, Purnima. First case. And can we have the full screen? So the panelists also have the option of raising their hands wherever they want to answer, and we will try to go one at a time. These are very clinical cases. They might have more than one answers, more than one opinions, but I would suggest everybody to go by evidence and by the guidelines, just say Dr. J.B. Sharma, the ones which are needed nowadays in accordance with the NTEP program. So case 1 is a 30-year-old woman who comes to your clinic with complaints of primary infertility 4 years, secondary amenorrhea 1 year, loss of weight, loss of appetite 1 year. Patient was married 5 years back. She attained menarche at the age of 13 years of age. And since menarche, since marriage, she is having hypomenorrhea and oligomenorrhea. Before marriage, cycles were perfectly okay. Mother had chronic illness of unknown nature and she died 5 years back. There is no other significant history. She did not have any consultation in the past for infertility except for some routine blood test in the local district hospital. On her examination, she is thin-built, her BMI is 90. Systemic examination and per abdomen and PV examination are normal. And this is the USG PICUC. So my question to Dr. Pragya. Dr. Pragya, can you describe the USG findings? Can you go to the first?
It's showing very thin endometrium. Its measurement is not written, but I hope it is like maximum 4 millimeter thickness, what it look like, and the triple line, that difference is not maintained. So this is very thin endometrium, and the history is showing that she is having amenorrhea rather. Initially, she had hypomenorrhea after marriage, I think it is written, and then she had amenorrhea for 1 year. Am I correct? I think this is the history. Secondary amenorrhea. So this is the picture showing atrophic, what the USG is look like atrophic endometrium, and she is having poor BMI. So her mother is having chronic illness, and though this is the seminar on infertility tubercular seminar, and that is not the thing, but all the things are pointing toward the tubercular endometritis, what I can see by the sonographic pictures. Because if she is having amenorrhea, it can be hypothyroidism and can be prolactin something like that, hyperprolactinemia.
Okay, so can any panelist, thank you, Dr. Pragya, can any panelist comment
I
on
would like
the
to make a
ultrasound
comment.
picture? I want the one
I would
feature on ultrasound picture which points towards tuberculous endometritis.
I would like to comment. I would like to comment.
Please,
Here
please.
in the endometrium, I can see a I think it is because since millimeter or endometrial thickness is not mentioned, so and we can see hypercalcified type of picture here pointed by the arrow. So maybe this is calcification, and that points us towards the chances of tuberculosis. And one more thing is important is in which cycle the endometrial imaging is done. If it is done in the just in the day 2 or day 3, then 3 millimeters is a
Basically,
normal
she is
finding.
having amenorrhea now. That's why we
No,
don't know.
we cannot predict by if she's having amenorrhea, then we should get a thin endometrium. We cannot say that. But by the picture which we can see here, we can see the calcification. So that I'm very, but that can give us hint that maybe she has a healed tuberculosis with calcification. And we need to see the check for the vascularity, what kind of vascularity this endometrium is having, and also by zooming, we can see the endomyometrial junctions, whether it is ragged or whether it is showing some else picture. And also we have to repeat the ultrasonography in the different phases of the
That's right, Dr.
maybe
Vinita.
later on in the.
So you're very right. The junctional zone will have subendometrial calcific spots. There might be a single calcific focus, but usually the junctional zone, which you rightly said, the endometrial myometrial junction, which is a very dynamic area of the uterine endometrium, which is of significance in infertility and many other pathological conditions, will start showing subendometrial calcifications. And as she is amenorrheic since 1 month, we are not concerned that much about the phase of the menstrual cycle, but she definitely has a thin endometrium. Next slide, please. So you have already described the ultrasound finding. What is going to be your line of management and investigations? You can go to the next slide, Purnima. Yeah. What are going to be your investigations?
Can I answer it, Monica?
Yeah, please do.
We very well know like this case is looking like that one because there's amenorrhea of 1 year. It looks like a case of tubercular endometritis, chronic endometritis. And endometrium is one tissue which is very easily accessible to diagnosis. As Dr. J.V. Sharma had pointed out, we can go for tubercular TB PCR and also send it for AFB and culture and wait for the confirmation of diagnosis.
Yeah. So
I would like to make a comment.
Yes.
Yes, ma'am. Yeah. What I feel is calcification. Maybe it is an old tuberculosis, so we need to take a detailed history first. Maybe she has undergone a treatment. Maybe she had some pulmonary tuberculosis. For detailed history is very important. And maybe by doing endometrial biopsy, we do not get anything. We do not get anything. It's not likely
I
we
think
don't
her
get
X-ray check should also be done because her mother was also having
her mother was definitely she died of a chronic disease. So her mother was probably tubercular.
Yeah.
She had contact. Now, when she says that her periods were normal before marriage, that every girl says in a middle class normal Indian household, no woman will say that I had scanty periods before marriage. Every time it is normal menses before marriage, and
Right.
after marriage the problem crops up because now they cannot hide
I
it.
think full workup.
I mean,
I think
Full investigations should be done. Everything should be done.
Full workup.
Medical profile and whatever
Yes, sir.
investigations.
Yeah.
Yeah, can you give the
And
next
after
slide,
that,
Purnima?
yes, sir.
Yeah. So you are sending her endometrial biopsy. Now, can please somebody describe the endometrial biopsy and the significance, when it should be done, which day you should prefer, and if the patient is a very affording patient, how many samples you will send and in which media, at what time
May I
of the
give,
We should
may I please answer, ma'am?
we should send the endometrial biopsy on the first menstrual blood or either in the premenstrual period. But actually, she is amenorrheic. We cannot identify the phases of the menstruation. So, and for the endometrial sample, we have to send it for culture and biopsy, PCR, and AFP microscopy.
Request everyone to please mute. The one who is not answering, please mute everyone else. Yeah. So Dr. Prakriti was the one who's answering?
Yeah.
Yeah. So now the guidelines given to us for endometrial biopsy in the ideal case is that the endometrial biopsy has to be taken with the proper cannula. It has to be either the Pipel biopsy or it has to be number 4 Carmen.
Yeah.
Idea is to apply a little bit of suction. And if these two are not available, you can use an endometrial biopsy curate. Out of these, the sample
Day 21 to day 20.
Yeah, if she is menstruating, the best time to take is between day 21 to day 24. If she is not menstruating like this, then you take the sample anyhow, and you have to put the sample in 4 different tubes. First goes for AFB smear, that is in normal saline. The second goes for culture. The culture could be an LG media conventional or it could be MGIT. The third goes for CBNAT, which is the most representative test recommended by NTEP, also known as Gene Expert. And the fourth can be sent in 10% formalin for HB, pathological examination. And any of 4 of these tests positive are diagnostic of FGTB. But suppose the tests are not positive. Suppose you don't get a positive result, then what do you do?
If they are not positive, then we go for other investigations like laparoscopy or hysteroscopy.
Yes. So in this case, the case has become simpler for you. Dr. Prakriti, you have sent a CBNAT for her. Can anybody tell me the full form of CBNAT?
Cartridge-based nuclear amplification.
Yes.
Nucleic acid amplification test.
Cartridge-based nucleic acid amplification test.
Yes, exactly. It is a cartridge-based nucleic acid amplification test, and this is highly sensitive and specific for detection of Mycobacterium tuberculosis. So if this test is positive in this patient, you do these other routine investigations, which everybody will do, AMH, TSH, Semen. USG picture you have already seen. And next, how do you proceed? This patient is CBNAT positive and you are having a private practice. Okay. What do you do? What do you do? A positive CBNAT patient.
We have to inform.
Yes.
We have to application to the government and then start her on ATT. 4 drugs for 2 months, 3 drugs for 4 months. And then do a repeat follow-up of the patient.
And then later on,
we can also
after starting this treatment.
Yeah, you're absolutely right about the treatment, but Dr. Anuradha and the rest of the panelists, I would like to know the method of registration. You are sitting in your, let us say, your hospital, a private hospital. And you are sitting, you have to register to your authorities in Chhattisgarh. How will you do it?
Yeah. There are separate TB wards are there, ma'am. TB hospitals are there from the government in district level. So we have to inform them that should be registered. We have to give written. She has to be prescribed anti-TB drugs and she has to report there, get registered, and they can get the medicine from there free of cost.
Dr. Anuradha,
It should be sealed and signed from our own seal signed, all our specific finding like endoscopy, CB not positive, all the
Yeah. All the reports they should have.
It is properly informed to them on paper also, and even I write the phone number of the nodal officer to the prescription paper to the patient, and from our hospital the information goes like the delivery report, MTP report. We have to report these patients to the nodal officer.
You are working in a very, Dr. Pragya, you're working in a very high-tech center, and you have a full-time computer operator, and you don't want to waste time. What do you do?
Immediately inform and start with it.
Government of India has
Yes. Go to the Nikshay portal. You will go to the Nikshay portal. You will see this is the Nikshay user guide for private sector TB care providers. You simply have to visit this website, http://nikshay.in. Click on the new health facility registration. Provide your hospital's basic details. Provide the mobile number of the patient whose registration is done. The mobile number is very important. Fill the details and everything will be done sitting in your hospital. But you are right, you can do it also physically. You can call up the call center, or you can, just do it on the computer. There is one more method, Purnima. You can either do on computer, you can do it physically, you can call up the call center, and number 4,
Mom,
there's one more option.
Either this is offline or online. So these are the options.
Yes. So you don't have to waste time. If you have a computer or you have somebody to do it, you do it.
We inform them about those cases.
Yeah, I'm talking about registration in this case because so many of us are not doing the registration. So many of us are not aware that it is so easy. The government is working so hard to make it so simple for us. Now tell me, this patient goes to Dr. Anuradha Tibrewal, and the next month she goes to Dr. Ritu Jain. And she tries to take treatment from both of them. And both these gynecologists are so hardworking and so able that they both try to register her on the portal. Now, what will happen?
She is already notified by Dr. Anuradha. So already the information will be there, and she would be already on the treatment of given.
She has not been started treatment, but she tried to change her gynecologist. So there will be duplication, and that duplication on the basis of patient's mobile number and her Aadhaar and verifications will be noticed by the portal, and there will be a duplication patient warning. So if the patient has got duplication, then she has to disclose, otherwise the enrollment will not happen.
Yes.
So can you
I have to mention one thing. You were asking other method also. So this is in our next slide, that you can just call Nikshay Sampark at 180011 and 6666, and you can provide the patient details and they will notify.
Yes. So this is how easy it has become. No need to fill pages, no need to write a letter, no need to call anybody. Just go on your computer or do a toll-free number, and you can get it done. Now, can somebody tell me about the incentives which are being given by the government, the state government, to these patients who are tuberculosis positive?
They get
500 rupees per month.
Every month for the treatment, so that they can buy food, high protein diet. And even in Chhattisgarh, they have come up with some incentive for doctors for registering, notifying these cases.
Yeah, this is there in all the states.
Yeah.
So the doctor who notifies will also get 500, and the doctor who notifies that she has finished the treatment, she or he has finished the treatment, will get 500. So this 500 you can afford to forego, or you can give it this incentive to your staff who is doing the job.
Yeah.
Like you have designated a particular staff that you will do the information, you will do everything. You take 500 rupees in the beginning and you take 500 rupees in the end. So this is a very good move by the government, because then anybody will not feel they are doing extra work. Okay. Exactly. So this is what I wanted to tell you about, just about the registration. Now this patient has taken treatment. So can somebody just elaborate the 6 months of treatment, how it is given?
It is in 2 phases. One is intensive phase, which is the phase 1, consists of 4 drugs, HRZE for 2 months, and then 3 drugs, HRE for 4 months.
Okay.
In case she lands up with some side effects, then we have to add injection streptomycin, ethambutol, and moxifloxacin in place of HRE, and then reintroduce one by one all these drugs once the LFTs come back to normal.
So we are considering, Dr. Ritu, that she has taken it very nicely, the 6 months of treatment. There is no complication, there is no side effect, there is no hepatitis, nothing. She finishes the treatment and she comes to you after 6 months. But unfortunately, she is still amenorrheic. Now what do you do?
You can give her some estrogen and try and make endometrial growth.
First, rule out pregnancy, madam.
Okay.
Yes. Yes.
Pregnancy.
Yes.
Look for her clinical improvement, her signs and symptoms, has they resolved or not? Apart from amenorrhea, is there weight gain or no? We'll repeat her sonography. As Pragya ma'am said, we'll rule out pregnancy, that is foremost, because patients do conceive when they are taking AKT. And also, if
any panelist is giving contraception to the patient during ATT? Any of the panelists giving contraception?
No, there is no need.
There is no need, because even if she becomes pregnant, these are now the further slides. If she becomes pregnant, the ATT is going to continue.
Continue.
And
And
so you give estrogen and progesterone, right?
I will also advise her for hysteroscopy.
Right. And this is
And,
the
and
follow-up.
also one more thing I want to mention, it might be that her ovaries are might also be involved in 15 to 30% of cases, then we can evaluate for ovarian function, whether her AMH is, what is her AMH levels, whether her ovaries are not destroyed. And we can also think that might also be the reason.
Yes,
And
madam. We have done her AMH, we have done her TSH, we have done the husband semen analysis, and now we do a repeat ultrasound and we give ENP for withdrawal. Next slide, Purnima. See, these are the findings. Her AMH is 2.1, her TSH is 2.1. She has got 4 to 5 antral follicles on both the sides. Husband semen analysis is normal. Now, after withdrawal bleeding, what do you do? First withdrawal bleeding has happened after completion of ATT. How do you proceed?
Diagnostic
Laparoscopy, hysteroscopy for tubal patency.
Why not? Why not HSG?
HSG is
endometrium
usually avoided.
No. If the treatment is given, if 6 months treatment is over, then we can go for HSG.
See, we have completed the treatment. We have
then we can do HSG.
Then we can do HSG.
For active tuberculosis, we avoid HSG, but once treatment is done, we can go for HSG.
We can go.
So, but then simultaneously, we have to assess the uterine cavity also, no, because there's so much calcification on it.
Hysteroscopy is needed, right?
Hysteroscopy is more indicated than the HSG.
Then go for
Both the things, madam, I think, because we need to know tubes also.
Yes, yes. So I was expecting a controversy over here. I was expecting some different opinions, because there is like one set of gynecologists who would just like to do a tubal patency testing because semen is okay, AMH is okay, follicles are forming, the endometrium will gradually grow with this ENP, and sometimes these some endometrial calcifications, even if they remain, they do not cause any harm as such. These patients do get pregnant if there is not any, gross damage to the endometrium.
You need to confirm the completion of treatment, whether it is histologically or that is cured or not. By taking
Yes. Now, who all of you would prefer to do a repeat endometrial biopsy for CBNAT or after the completion of 6 months of ATT?
He's affording her.
CBNAT will show up live and dead specialized, so there's no point in doing CBNAT.
No need. No, but the guideline says that we should repeat CBNAT after 6 months or 1 year of completion to confirm that the treatment has been effective.
When the patient is in not in good follow-up.
We'll give you the answer. Purnima, what are the guidelines? Purnima, what are the guidelines?
And CBNAT is free of cost for the
guidelines says that we have to confirm the full treatment of the patient, and if we have sent initially the endometrial biopsy and it is showing CBNAT positive, then you have to again take the endometrial biopsy and then you again have to send the sample. But if the patient is financially poor and you cannot again send the CBNAT and patient has resumed menses, patient has improved clinically, then it is your individualized choice whether to again take the biopsy and send the sample or to treat the patient for infertility or further management.
So what is the answer to my question that CBNAT will also be positive for the dead bacilli? Now that
No,
if
no,
CBNAT
ma'am.
confirms, and how can you?
So CBNAT has got
No,
no
ma'am.
very
Only
high specificity.
PCR is positive for dead and live bacillus. CBNAT is positive for
active tuberculosis.
PCR, the
PCR is positive for
PCR is-
dead one.
Both
Yeah.
dead and live.
And nowadays, PCR is not considered as a test to be reckoned with. Nowadays, the recommendation is if
Genetic
PCR
and
is
genetic.
positive, you do not label the patient. You label the patient on the other test. Other tests being microscopy, second being culture, third being CBNAT, fourth being histopathology. PCR is nowadays just an indication that you should go forward with other investigations like endoscopy, ultrasound, imaging, etc.
Yes.
So this patient has got bilateral tube patent. You have done a diagnostic hysterolaparoscopy, but unfortunately on hysteroscopy, you found a very pale looking endometrium. And still on day 14 of the cycle, she had an endometrium of 3 mm with very poor Doppler flow. What further management? Now resistant thin endometrium she is becoming. What do you do?
One option
We
is that
can
we
give
can think of PRP.
PRP.
PRP is the current which is coming up, and also by
Endo-
Sunita Madam's
Like
lecture, I got
Madam
to know
said.
about stem cells. Yeah, got to know about stem cells. So, but I have no experience with PRP. I've heard from anyone, but I have myself not done. But they are saying that it is really works, that PRP installation in the endometrial cavity using hysteroscopic
Right,
guidance.
Purnima?
My experience with the PRP is like not good every time. Hardly like in 1 out of 10 cases, there is good endometrium, which I think that maybe chance by chance. So I don't know PRP work. I cannot say it work 100%, but more what I see that if we dissect and in hysteroscopy, even I did a case with Palak Madam, very bad patient, if Palak Madam remember, and that patient conceived naturally. So good surgical skill is the baseline, I think, in the hysteroscopy. If we make the cavity proper dissection of these synechia and all these things, they work very good.
Okay, so now you can see the laparoscopy findings of this patient. She had extensive abdominal peritoneal adhesions. The tuber-ovarian relationship was disturbed. The ovaries were looking normal. There was chromoperturbation test. The dye was seen on both the sides spilling. But you had this endometrium affected. So probably she was that 25 to 30% of cases of genital tuberculosis where the endometrium is damaged. And since it is damaged, you have a thin endometrium, and thin endometrium is the bane of a practicing ART specialist. We know how difficult it is to deal with a thin endometrium, to the extent that sometimes you have to advise surrogacy. And now surrogacy, you have to advise with all the ART law considerations in place. So with leaving this answer open, we move on to the next case. Purnima, you too, go ahead.
Thank you, ma'am. So we move to our next case. This is case number 2. A 33-year-old woman presented with primary infertility since past 5 years, irregular bleeding with postcoital bleeding since 6 months, vaginal discharge, dyspareunia, backache, pelvic pain since 6 months. She had history of pulmonary tuberculosis 5 years back. She took ATT for 2 months only, but left treatment in between as her symptoms improved. In examination findings, GPE and systemic examination was normal. On perispeculum examination, primal irregular growth on cervix seen, which bled on touch. And we did her transabdominal scan. ET was 7 mm, uterus and bilateral ovaries normal. On day 10 of menses, she presented as she was still having spotting. We did her careful TVS. ET was 7.6 mm with good triple line and intact junctional zone, AFC 3 to 4 on both sides. So my question to the panelist is, what is the probable and differential diagnosis which come into your mind after seeing this case?
Tuberculosis of cervix with different
Cervical carcinoma, tuberculosis cervix.
Yes. Tuberculosis cervix, we will think first because she is already having history.
Yeah.
Yeah.
That is also in the DD. CA cervix is also in DD. Any polyp, any growth.
Yes, as we can see that the history, patient is having irregular bleeding, postcoital bleeding, discharge, backache, pelvic pain, and there is no history of previous pap smear done. So as soon as this patient come to your clinic and you see the patient, you say, okay, this is CA cervix, this is dysplastic cervix. So that is the first thing which should come into your mind. Okay.
And yes, she has history of pulmonary tuberculosis, but still the cervical tuberculosis is still rare. It is
Rare.
very rare. So the more commoner thing should come into your mind first as the diagnosis, and the less common thing we should put the next DT. So my question is, okay, how will you proceed? You have seen this patient into your clinic. Now, how will you proceed with this patient?
Any other differential diagnosis, Purnima, besides this chronic granulomatous?
Other granulomatous conditions can also have this kind of presentations, but these are very, very, very rare in Indian scenario. Like amoebiasis, schistosomiasis, brucellosis, tularemia, sarcoidosis, and foreign body reaction. And I think most of us agree that in our practice, we have never seen these cases. So, yes. So my question is, how will you proceed with this patient?
Tribal material to be sent for histopathology first of all.
Yes.
And the routine anatomic workup, CBC, ESR, chest X-ray.
Yes, yes.
Everything added. And histopathology will help us here.
Yes. Any other opinion, like just to send histopathology or to send?
No, we can send other TB tests also by cervical ulceration. If you're seeing, we
Right.
take
He has
take the
left
sample for other test of TB also. No?
pulmonary
CBNAT also we can
tuberculosis.
get.
Also, she had left the treatment.
Was
for
a
2
deep
months only.
pulmonary tuberculosis, so chest X-ray, sputum, mount of testing can be done.
Yes.
These will give us a supportive diagnosis. Because we hear the main symptom is postcoital bleeding, so we need to first rule out CA cervix and then work up in the direction of tuberculosis cervix.
Yes. So of course, yes, ma'am.
Yeah. Do you anybody would take a simultaneously endometrial biopsy in such a patient while taking a biopsy?
Yes, yes,
Yeah,
we must
Yes.
I'm taking
we must do
cervical
LV
biopsy,
also.
so in sitting, I'll take endometrial biopsy, and the same way as you said, in 4 containers: culture, smear, histopathology, and gene expert.
Yes, definitely. Of course, we
I
have
want to add something, Purnima. Dr.
Yes,
Shabana.
ma'am. Yes, ma'am.
Actually, I encountered 2 of these cases in my whole career, which make a confusion of CA cervix with cervical tuberculosis. Well, we all very well know that we are going, whenever we see a bad cervix, we should proceed with a simple test of VIA. That is very important. That is visual estimation of by acetic acid. And this plastic cell, they look like white in color, but cervical tubercular cell, they are not giving any acito-white area. One very important thing is this when we proceed for these type. Obviously, we go with the colposcopic evaluation of that bad cervix. We'll proceed with the colposcopic evaluation. And because these type of tissue, tubercular cervix and CA cervix, both by look, it is total similar. But when a carcinoma in C2 or a CIN grade 3 is there, it always produces a acito-white patches. But cervical tuberculosis is not producing any acito-white patches. We may proceed with the cervical biopsy, but a simple test of VIA will add on it. Thank you.
Yes, thank you, ma'am. As you rightly said, acito-white area and iodine negative areas will be dysplastic cervix. As we are seeing growth here, so we can take the biopsy also from the lesion and then we can send it for histopathology. Thank you, ma'am. And okay, so we have to examine the patient thoroughly to rule out any lymphadenopathy or other sign of tuberculosis or cancer, and then we have to send the biopsy. Yes, we have to be very cautious because she might bleed. It is a very vascular. In fact, tuberculosis of cervix is also very vascular lesion. And this case is actually from our case report where we had bleeding in this patient after biopsy. And suppose this is the slide. This is the biopsy slide. So what is your interpretation and how will you proceed with this patient and what other investigations you would like to do in this patient?
So can anybody describe these slides? I think Dr. Ritu or whoever is seeing. Yeah.
Yes, granulomas. This right-sided picture is showing clearly.
Yes,
Langerhans giant cells are there.
Yeah, Langerhans cells, which are pathognomic for tuberculosis. And as was discussed, the other investigations, the AFB on smear, culture, and gene expert will also help us. And since she was a defaulter with a history of pulmonary COX, we have to do her chest X-ray, find search for old lesions, healed lesions, or maybe active lesions as well. And ultrasonography will help us to see the adnexal tumor masses if there are any involvement.
And also check for drug resistance.
And yeah,
in case
So
it's
this is a better
persistent.
picture of the biopsy and the mycobacteria. You can see the,
Because yes,
yeah.
what I feel that as a gynecologist, we are far away from the pathology and microbiology. So I thought of putting these slides. These are granuloma and these are Langerhans giant cells.
Right,
Which is pathognomic of acid fast bacilli, Mycobacterium tuberculosis, and in the same slide, and these slides are ZN stain and AFB, we can see these little tiny bacteria, acid fast bacilli.
And yes, HIV, HPSAG viral markers
Yes,
are.
yes.
Yeah, so this is an important message which Dr. Purnima, you would like to hint on the why do we do HIV and sugar testing, and then I will tell you what Bhopal district is doing. Yeah.
Yes, because this patient is a defaulter case and she's having primary tuberculosis of cervix. So we have to rule out the other immunocompromised states as well. So we will send the patient for the integrated counseling for HIV, and we will send the blood sugar fasting to rule out diabetic status. And yes, of course, as Monica ma'am asked, that when we will do the endometrial sampling is a question. Sometimes we get a case of tuberculosis of cervix where the entire os is embedded into the growth, and you cannot negotiate your PIPL or Kahnemann's during that time only. So during the follow-up visit of that patient, you can take the endometrial sample.
So yeah, you can describe the PIPL, Purnima.
PIPL, it is very thin pipe and it is easily negotiable, and this is stillet and it is used to create the suction, and this PIPL cost hardly around 150 to 200 rupees, and it is patient will not have pain and you also will be very comfortable in taking biopsy with this PIPL. Monica ma'am, you were telling something in Bhopal?
Yeah, so I talked to CMHO Bhopal yesterday, who happens to be my classmate, my batchmate. So I asked him, Dr. Tiwari, what is the status of TU, tuberculosis units or the sub-district centers in Bhopal? So he told me that after NTEP has been implemented, Bhopal district has been really doing well. We have about 33 tuberculosis units and about 7 centers in Bhopal where CB-NAT is being done. Everything is free of cost. We have these FDC or fixed drug combination tablets being distributed. In the subsequent case, we'll tell you what FDC, we'll ask you what FDC is made up of. And at present, there is 100% coverage in Bhopal district for detection of HIV and for diabetes screening in all the patients who are tuberculosis positive. So that is a commendable step, which I got first-hand information from the person who is working in the government.
That's great.
So Purnima, carry on.
So my next question to panelists is what treatment you will give to this patient? Suppose the patient is having weight of 50 kg. So, how many drugs of FDC you will dispense, or you will ask the dispense, and then how will you give the management? Any panelist?
So you must have seen all our panelists. These patients from government centers, they are coming with these brown
Yeah, dot
tablets, you know.
center.
Yes. So can anybody tell us what is one FDC tablet made up of? What are the contents?
Which is HRZE. So 75 mg isoniazide, 150 rifampicin, 400 is pyrazinamide, and ethambutol is I think 275.
Yes.
So that one cc and 50 kg women, we need to give 2 tablets daily orally under the DOTS therapy.
No, for 50 kg you have to give 4 tablets.
4 tablets initially.
So we all know that it is a 6-month course, 2 months intensive phase HRJD and 4 months continuation phase HRE. Here in this table, we can see that for 50 kg patients, you have to give 4 tablets in the intensive phase and 4 tablets in the continuation.
And you see, this OPD, in your OPD, when this patient comes to you with this big government ka patta, you know, with all these tablets, you ask her how many tablets, madam, I'm taking 4 tablets daily. Sometimes you are also shocked, you know, because you are used to seeing that small, smart AKT4 pack strip, you know. Yeah. So now patients are coming with that huge FDC strip. So that is why the government has made it so easy. Everything is now in those tablets, and you just have to calculate. Wait, just memorize patient less than 50, more than 50, and you will know the number of tablets.
Yes, and along with these tablets, pyridoxine 40 milligram OD will be given.
Yes, yes.
As prophylactic. Yes.
Yes.
So that is why we made a slide so that everybody knows what good work our program is doing.
Yes. Suppose during follow-up, if this patient develops loss of appetite, abdominal pain, yellowish discoloration of urine and eyes, and malaise after 4 weeks of intensive phase, so how will you proceed with this patient? She has come to you saying, ma'am,
There is hepatotoxicity in this patient. So
Yeah,
we
she's
for
having
elective
side effects.
Liver function.
what are the side
Yes.
effects?
Liver function test should be done.
RZ, and we need to introduce her on injection streptomycin, continue with her ethambutol, and add levofloxacin or moxifloxacin, whichever she's sensitive to.
Yes.
There are tests also for the particular drug sensitivity test that patient will respond or not.
We will get that rifampicin drug sensitivity itself.
Right.
Yes. Because
any other question about hepatitis management in this case you want to ask Dr. Purnima?
Yes, first of all, yes, as soon as this patient comes, we will get the liver function test done. And what values you will see in that LFT report exactly to confirm that this is hepatitis and to manage that further.
No idea.
Bilirubin, ALT, AST, right?
Yeah.
So these are the guidelines which government has given to us, that if a patient is coming with clinical symptoms, so just look at the report of ALT and AST. If it is increased to 3 times to baseline and bilirubin increased to 2 times of upper limit of normal, then confirm, okay, this patient is having hepatitis. Now what next? If this patient is just coming with no symptoms and you have got the LFT done, then ALT, AST should be increased to 5 times to label it as hepatitis. Then you have to exclude the other causes of hepatitis as well, because it is not mandatory to be drug induced only. So exclude hepatitis B, hepatitis C, hepatitis A, E. You have to get the coagulation profile also to get it done. If it is deranged, directly send the patient to the higher tertiary level to the physician. We cannot manage this patient in case of coagulopathy. And then we have to get the ultrasound liver as well done, right? So suppose, because this is the case of primary tuberculosis of cervix and patient is having drug-induced hepatitis. Now I want to ask my panelist, will you stop ATT or you will replace the ATT with other drugs? HRZ with other drugs.
Replace.
We can replace. We can
Replace with the safer options.
We can put her on LRZE for 6 months.
Yes, but
you can also
I also knew this, but the guideline says if there is no need of urgent ATT in this case, you
can
stop the
evaluate her
ATT
first.
for 1 week and then repeat LFT after 1 week. If LFT resolves, you restart the ATT in the same manner.
Same drugs.
Right? If this would have been a case of tubo-ovarian abscess, high-grade fever, very bad condition of the patient, and you cannot stop the patient ATT at any cost, then you have to start the patient on streptomycin, ethambutol, and levofloxacin.
SEL.
Yes.
Short form is SEL. 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 If you don't. But there are hardly any instances in genital tuberculosis where it is very urgent to continue ATT.
Yes.
The best is safest is to wait for a week, repeat your LFT, and if the LFTs become normal and the patient's constitutional symptoms resolve, then slowly you start ATT again.
Yes. And if anytime you feel that your patient is not improving in LFT or there is deranged coagulation profile or any complication is there, you directly refer that patient to tertiary care center, right? So this is the regime where how to reintroduce the ATT. I will not go into detail. This is sequential regime and it is incremental regime.
But we would suggest everyone, all the panelists, please go through it, because like we have enjoyed preparing the questions, you'll enjoy reading it, and it will definitely add to your clinical acumen.
Madam, please do share the PPT, very nicely made.
So my next question is to the panelists, how will you follow up this patient? This is happy ending of the patient. This is follow-up pick of the cervix. Everything has gone and this is good looking cervix. And these are the investigations. Suppose you get AMH 2.1, TSH 2.2, HSA normal, AFC 3 to 4 on both sides. How will you manage this case, infertility in this case?
Tubal patency first.
First of all, we will do tubal patency. If tubes are patent, then we can go for normal treatment.
Next slide, Purnima.
So tubal patency by HSG, everyone agree?
Yeah, we
Yes.
can do, yeah. We can always do by SSG, and we can try 3 to 4 cycles. And if she's not responding, then we can think of DHL then.
Yes, yes, definitely. So tubal testing, HSG can try for natural cycle. So these are my references. The first is our case report only, and she was our patient only, and she happily had menses after 6 months, and then she conceived also after 4 months of treatment completion and delivered also. Thank you.
Oh, great, congratulations.
So case number 3, we'll just rush up now because it's going to be 7:30. So as you can see, a typical picture, a 32-year-old married woman, primary infertility 7 years with chronic pelvic pain, loss of appetite, dyspareunia, weight loss. And now this is her husband after marriage. He had cough with expectoration and he took ATT for pulmonary tuberculosis. When you examine this patient, her BMI is 20, which is not unusual in Indian patients. Per vaginal, please mute yourself, people who are talking. On per vaginal examination, you see a soft 3 centimeter by 3 centimeter adnexal mass in the left adnexa. And I really congratulate those who still do a PV, because many of us are just putting a TV probe. But people who missed doing the PV, they saw on TV probe this swelling. And you had a beautiful 3D Voluson and you reconstructed the image and you got this image. So everything is in front of you.
So she has a positive family history with active case at home. So definitely the diagnosis is towards tuberculosis with PV findings suggestive of either TO-MOSes or USG suggesting hydrosalpinx.
Yes.
So we put her on AKT.
Yeah. Next slide, please. Diagnosis USG. Now tell me, with only her hydrosalpinx, now she has got husband, a close contact who was positive and who took ATT. And on ultrasound, she is having a hydrosalpinx. Would you start her ATT without doing any endometrial biopsy? Is there any provision?
We should take the biopsy or we should test her for tuberculosis first.
Now, according to the guidance, we need
clinical
some
suspicion.
microbiological evidence to put her on AKT. But the problem
No,
is
it's not that. It's not like that. Even if there is a strong clinical suspicion, we can start anti-tubercular drug.
Anything on the endometrial biopsy.
What do you say, Purnima?
Ma'am, yes, in this patient, we can take the endometrial biopsy, but the positive report is not necessary to start the ATT because she's a probable case of female genital tuberculosis.
Yeah, because strong clinical suspicion.
Yes, you can start ATT.
So wherever there's a strong clinical suspicion with corroborative imaging findings, whether on endoscopy or ultrasound, that is sufficient to label the patient as probable FGTB. And probable FGTB will be treated in the same way as a confirmed FGTB.
So we will notify this case as a possibacillary, ma'am. And we'll notify
this patient as a tuberculosis, undergoing tuberculosis, and she is fit to get all the benefits as a beneficiary of the NICSHE program.
Yes.
Yeah. Yes. Okay. Thank you.
Will the management change if CBNAT comes positive or negative? The answer is
no, it will not change. No, it will not change.
It will not change. So the circle which has been made is very important. PCR is not for diagnosis or labeling a patient as tuberculosis positive or negative. PCR is just your guide that go ahead with either endoscopy or radiological tests. And once you find definite findings on imaging or on laparoscopy or hysteroscopy, which are either definite or probable, you have to start AKT. Only when your imaging, your laparoscopy, hysteroscopy are completely normal, despite being PCR positive, you will not give ATT.
Yeah.
Yes.
Yes.
So these are the tests for FGTB we've already discussed, Purnima.
Yes.
So, yeah. So the four tests, which are, this is a beautiful article by Professor J.B. Sharma. Please, you go through this article. It is like, Gita, Ramayan, Bible of tuberculosis.
Yes,
You're all set.
it's
Now,
very
very, very good. And these are the two latest tests which are there. That is the next generation sequencing and nuclear receptors. So the way India is going, and I'm proud of the work India is doing, there will be some now, these new tests which will be available at least in the big centers or in big government setups. Next slide, please. So she has got, one more question. This is related to ART. On diagnostic histolaparoscopy, this patient had the right tube patent and healthy looking and the left tube hydrosalpinx. How do you manage?
AKT has to be given.
AKT
And then
has been given. AKT has been given.
we look whether the hydrosalpinx is still there. We need to remove it and then go ahead with our treatment.
Yeah. So like we listened to Dr. Sunita Tendulwadkar's talk, sometimes simple clipping is not enough. Sometimes you have to do a salpingectomy. And like now you have done clipping for for hydrosalpinx and the right tube is patent. What is your experience with a single patent tube after ATT? How many times you get a normal intrauterine gestational sac, and how many times you land up with ectopic or no pregnancy?
High chances of ectopic.
But in my experience, I have got a patient conceived. I've got a patient conceived. We also got ectopic. So varied experience, madam. Not we cannot say that ye hoga wo hoga, but there are patients who did conceive and delivered finally. But then there are patients who landed up in ectopic also.
Luck in that case.
Exactly. So Vinita ma'am is absolutely right, considering her experience in her institute, that the patient has to be explained about the risk of an ectopic gestation and leave it to her whether she wants to have no risk for ectopic, she can be offered IVF. But if she can be, as I think the fundamental area where you can improve on is by, detecting the pregnancy early and go for as early detection of the intrauterine sac as possible.
Yes.
Because now there is hardly any ectopic which is diagnosed early and cannot be treated medically. So even if you get an ectopic and you catch it early and you treat it early, you are fine. And I can share my experience. So many times I have got ectopics which have become missed in very early gestation. I just followed up the ectopic very, very carefully. I'm a totally TVS person. I mean, any money I have, I just buy a machine. So the ectopic can be caught very early, and in front of me there was an ectopic sac, pregnancy in the fallopian tube. I could see the sac, I could see the yolk sac. Before I could give and counsel the patient on methotrexate, her beta HCG fell regularly, and within 10 days I could stop seeing the sac. So this is sometimes the intraluminal ectopic pregnancy also has the same fate as an intrauterine missed abortion.
Yeah. And ma'am, I would share my experience. Once I got a patient, she had ectopic also and she had intrauterine also in the same cycle, the heterotropic pregnancy. I did the ectopic surgery and continued with the heterotropic, and she delivered with me only 2-3 months back.
Yeah, so this happened with me also right in the beginning of my IVF practice. That time I had to do laparotomy because she came with a ruptured ectopic. At that time we were transferring 3-4 embryos routinely. This I'm talking about 2008. 2008 we were transferring 4 ban gaye 4 dal do. 3 ban gaye 3 dal do. So heterotopic and lot of culture media was being used by the embryologists, So they were pushing large boluses. So ectopic was very common, but we also did it and the patient delivered. Okay, next.
Should we take case 4 or next to case 5? Case 5 is pregnant patient.
हाँ, case जो भी लेना ले लो. Case 5 ले लो.
Case 5.
Yeah. Here we'll be able to give a message and we can wind up then. Yeah.
Should I take now?
Yeah. Yes, please.
Yes. So a 30-year-old woman came with complaint of primary infertility 5 years, irregular menses since 2 years. She took ATT 3 years back for 6 months for permanent tuberculosis, treated completely. and no other significant history was there. On examination, it was absolutely normal. Investigation, ultrasound, average endometrium 7.5 mm with slight irregularity of the junctional zone. Endometrial biopsy you took and it was CBNet positive. Gene expert, drug sensitive was shown and patient was started on ATT. Now, as you are her gynecologist and she came to you after 6 weeks of treatment and she's with UPT positive, amenorrhea and UPT positive. So I want to ask my panelists that how will you proceed or how will you manage this case? Pregnant patient on ATT.
She was drug sensitive, so we will continue
Continue the drugs.
Yeah, continue those drugs. And if in case she was an MD, we do advise MTP in those cases, not in this.
Yes, very well said, ma'am, that because she was a drug sensitive, we will continue ATT with careful monitoring. Yes, of course, we have to monitor, in the first trimester, we will do the NT-NB scan with double markers and 18 to 20 weeks detailed anomaly scan. We can offer her chest X-ray if needed, but not needed in this case probably. And as we know that high energy requirement is there, extra calories she will need. And under NICSHEP program, as we all know, that 500 rupees per month she can get for her nutrition. And yes, and we have to ensure the contact tracing as well in this patient, right? So if gene expert suggestive of MDR TB and patient was on treatment of MDR TB with UPT positive, what management will you advise at 6 weeks?
If she
is
for termination,
termination, we will advise now.
But if she
but patient says कि बहुत मुश्किल से हुई है pregnancy नहीं terminate करना है, then what we should do?
Second line drugs, we have to avoid her kanamycin, streptomycin, and ethaniomide, because these are phytotoxic, and we have to work with the remaining drugs, second line drugs.
Yes, so this is the flow chart which Government of India has provided to us. Like if the pregnancy duration is less than 20 weeks, as in our case, we have to advise MTP. If she is not willing, then we can start. There are two regimes for the MDR TB, longer one and shorter one. If patient is pregnant, we have to put her on longer regime because it certainly avoids phytotoxic drugs, few phytotoxic drugs. It contains bedaquiline, though its safety is also unsure, but not phytotoxic. So yes, we have to ethionamide. If we have to give ethionamide, we have to give it after 32 weeks of pregnancy, right? And amikamycin in postpartum periods only. So longer regime, ethionamide after 32 weeks. That is my message. And longer regime duration I have already told, and this is the flow chart. It is for 18 to 20 months. In longer regime, we give these 6 drugs for 6 to 8 months and 4 drugs for 12 months, right?
Yeah.
So if we have done MTP for this patient, so how will you counsel for future fertility?
We will complete her long regime of 20 months and then review her clinical status, her symptoms, whether they have resolved, and then advise her for conception. In case the protocol remains the same, if the tubes are patent, endometrium is good, ovarian reserves are good, she can have her natural conception. If tubes are blocked, she can go ahead with IVF-ET, provided the endometrium factor is good. If the endometrial factor is also affected, then go for surrogacy. And if all the 3 factors, ovary, tubes, and endometrium are affected, go for adoption.
Yes, and the most important, we have to advise the patient contraception.
Yeah, yes, definitely.
Till when she is taking MDR TB treatment, she should not conceive again.
Contact tracing is very important.
Yes. Thank you so much. Over to you, Monica, ma'am. Next.
I think you have explained both the cases, case 5 and case 6 in one. So we will, you can show this picture, Purnima. I think this is the end stage, I think hysteroscopic picture showing dense intrauterine synechia, where we will require all the techniques, PRP, stem cells, and everything in order to get this cavity working. Though there are reports of patient conceiving even with 3.5 mm of endometrium, but that is very rare. And in Indian scenario, how many attempts of IVF you can do in a patient? In the self-funding patient is also a question mark. So I think that brings us to the end of our panel discussion. And just one carry home message I want to give you. And I think you had some beautiful carry home message slides, you know?
Yes, ma'am. I'm just
Yeah,
sure.
yeah. Please. Purnima,
Yes.
yeah.
Thank you, ma'am. So final is that if you have to send one test on any biopsy or fluid sample, that should be CBNet. If patient says कि पैसे नहीं है, ज़्यादा नहीं भेज सकते, just send CBNet.
It is free.
Yes. Do not send plain PCR. It is not of value in NTP. Just send CBNet. The second is if less tissue, you have received very less tissue, less than 500 microliter, then you directly send the patient to the tertiary care or medical college for culture. Because with culture, they will get the more DNA or RNA sample and then they can do the more testing. Do not. Yes, drug sensitivity also. Do not waste that sample by sending into peripheral lab. The third important point is if you have clinical suspicion of female genital tuberculosis and any positive finding on laparoscopy, hysteroscopy or radiology, start ATT even if all the tests are negative because she is a case of probable FGTB. Now, fourth point is always notify such patient on NICSHA platform. It is a crime not to notify by us. So please notify these patients. This is beneficial for patient also. Let me tell you one more important thing that we register the patient on NICSHA platform and we have sent the sample to the another lab. Lab is entering the report on the NICSHA platform in the same ID. So you will get the idea about the report also. Plus that if that lab is sending the sample for CBNet for drug testing, the microbiologist will enter what genes are present in that sample for drug resistance. So the NICSHA platform will automatically convert that report into the which drug sensitive that tissue is. So as a clinician, you will have idea about everything, positive, negative, drug sensitivity. Plus the patient will come to you for follow-up. You enter the treatment outcome. So all the person in the loop will come to know about the treatment outcome as well, drug sensitivity, resistance, everything. Plus patient will get money also for nutrition. So please notify the patient on NICSHA.
Yeah. This is a very good message we are giving everyone. I think, Purnima, we start the charity from home. And, everybody should follow, then surely we can achieve our target. I mean, such wonderful thing it will be if tuberculosis can be eliminated.
Yes.
So where everything seems cloudy, open your inner eyes to see the sky. Sometimes in FGTB, guidelines and literature cannot help completely. Our decision varies from patient to patient. It's a Pandora box for infertility specialists. And it's a wonder how this one little bacteria can affect the female genital organs and still remain a mystery. Thank you so much.
Thank you, ma'am. Thank you. Very nice questions.
Thank you.
TB हारेगा, देश जीतेगा.
Yeah.
Yes. Right.
It was very nice talk and the panel discussion.
Very nice.
We are close to 4 hours. 4:45 we logged in, it's 7:45, and I'm so thankful to all our brilliant faculties. The speakers have been wonderful and the panelists have been extraordinary. And Purnima, you have been wonderful, preparing everything and making me study.
Thank you so much, ma'am.
We also studied the topic. After MD exam, I think I read it in detail this time.
Yeah,
after
it was wonderful interacting with all of you, my teacher, Dr. Abha Singh, my colleague, Dr. Manoj Chilani, and of course, all of us in Bhopal Obstetrics Gynae Society, Chhattisgarh chapter officials and delegates. It was wonderful.
I thank you, Dr. Monica ma'am and Dr. Ranveer Singh sir for giving me this wonderful opportunity. And generally we say new girl in the city. I was a new gynecologist in the city, and then ma'am held my hand and showed me the path when I needed the most. Thank you so much, Monica ma'am and Ranveer Singh sir.
And Dr. Purnima, this is your just beginning and you have to go ahead a lot, and we need a academician like you people. So thank has been done by Dr. Monica, but I think along with the Central ISA, Dr. Nandita ma'am, Dr. Sunita ma'am, Dr. Sujata ma'am, and all the speakers, and the end, the platform has been given by the INTAS. So I thank to the Dr. Durga, the CEO of the INTAS, and all the team, and Dr. Vital is there. So I think we can wind up.
Yeah, Dr. Shabana, can you please give the vote of thanks? Is Dr. Shabana still there? No, she is not there. So I'll be giving the vote of thanks. Thank you so much, our ISAR officials, President Dr. Nandita Palshetkar, our Honorary Secretary General Dr. Sujata Kar, and our Senior Vice President ISAR Dr. Sunita Tendulwadkar for this wonderful platform on which we are sharing Perfection Series, Season 3 on genital tuberculosis. The next episode is on fetal medicine and ultrasound in infertility, which is going to have lots and lots of exciting videos, images, and great speakers from all over India. I'm promising to give you even more and more every time. The date which is expected is 24th of May. And after that, on 14th of June, we are having another exciting series with Orissa chapter. 24th May is with Gujarat chapter. These are a few links by which you can, enter into the world of genital tuberculosis and eliminate this scourge from the country forever and forever. Thank you, Intas Pharma, for being always there with us, especially Dr. Vishal and Mehul Prajapati and Mr. Ronak from the tech team for giving us these beautiful flyers and info sheets, Facebook pages, and the platform. Thank you so much.
And in the end, I request everybody that please, as I discussed that our presidential candidate, Dr. Sunita Tendulkar ma'am, is unopposed, you think, but still we have to work and we have to support her. Thank you, everybody.
Good night.
Good night.
Good night.